Good morning or good afternoon, wherever you are. Bonjour à tous. My name is Mel Kapp. I am chair of the board of directors of Canadian Blood Services. Je suis le président du conseil d'administration de la société.
Chair of the board of the Canadian Blood Services.
This open board meeting is taking place virtually due to the public health measures still in place across the country. Hopefully next time we can meet face to face, and I certainly look forward to that. Since we're all participating from different remote locations, we ask for your patience. There may be the occasional pause as we transition between speakers. In the spirit of our organization's values, which include integrity and respect, we begin our proceedings by acknowledging the traditional territory from which we're presenting. Now, in light of this meeting's virtual setting and the fact that we are not all gathered in the same place, I will acknowledge the territory from which I am addressing you, which is the traditional territory of many nations, including the Mississaugas of the New Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. Recognizing traditional territory in this way is a formal expression of appreciation for Indigenous cultures across Canada, and one we are glad to include in our meetings. I'd like to also acknowledge that June is Indigenous History Month, highlighting and celebrating Indigenous cultures, as well as contributions by Indigenous peoples to our work at Canadian Blood Services, employees, donors, volunteers. All of that is one of our goals. However, I would be remiss not to acknowledge the devastating discovery at the former residential school in Kamloops a few weeks ago. This was a terrible reminder of the devastation caused by the residential school system. It was also a reminder that the trauma is ongoing and that injustices and inequities are still experienced by Indigenous people and their communities across Canada. Canadian Blood Services has a role to play in improving relationships with these communities and building trust with Indigenous peoples. The progress we make is important in helping us better meet the needs of Indigenous patients. June is also Pride Month, and Canadian Blood Services is spending time acknowledging the work we have to do with LGBTQ+ communities as well. We've been criticized for our blood donation policy, deferring men who have sex with men by those who are ineligible to donate. Our goal is to move toward a sexual behavior-based model for screening donors, rather than the current 3-month deferral for men who have sex with men. We will have a science-based policy based on epidemiology and geography. We're aware that our incremental changes thus far have not moved quickly enough to satisfy certain groups. Our priority is to ensure the safety of the blood supply. However, we know some of our screening practices cause pain to some who seek to give. This will be discussed at length during our CEO, Dr. Graham Sherr's presentation, and later in our stakeholder conversations. And we look forward to your questions and to having a productive conversation. J'aimerais maintenant vous présenter les membres du Conseil.
I'd like to introduce you now to our directors.
Overall policy direction of Canadian Blood Services, and they play a key role in holding management to account. The board consists of 13 people appointed by the organization's corporate members, the provincial and territorial ministers of health. So let me just call on them and ask them to introduce themselves, and we'll go from east to west, and we'll start with Vic Young.
Hi, everybody. I'm Vic Young from St. John's, Newfoundland and Labrador.
Next, Dr. Jeff Scott.
Good afternoon. My name is Jeff Scott. I'm an Atlantic Regional Representative, and I'm based in Halifax in Nova Scotia. Welcome.
And Judy Steele.
Good afternoon, everybody. I'm Judy Steele, and I'm also based in Halifax and representing Nova Scotia.
And Glenda Yates.
Hello, everyone. I'm Glenda Yates, and I live in Ottawa.
And Glenda's the vice chair of the board. David Lieberg.
Good afternoon. Good morning. David Lieberg in Toronto. I am a consumer representative.
Dunbar Russell.
I'm Dunbar Russell, was appointed by Ontario to the board and I live in Toronto, Ontario.
Kelly Butt.
I'm Kelly Butt, a proud member of this board, living in London, Ontario.
Thank you. Bob Atkins.
I'm another consumer rep on the board from Winnipeg, and I appreciate the opportunity to participate today.
Dr. Brian Postal.
Good afternoon. I'm Brian Postal, presently at the University of Manitoba and living in Winnipeg, Manitoba.
And Lorraine Musqua.
Greetings to all. I am the Alberta Saskatchewan representative. I am in Treaty 8 territory in my home community of Big Stone Cree Nation. And thank you, Mel, for the great intro.
Thanks. Craig Knight.
I am the BC Yukon representative to the board, and I live on the traditional territories unceded by the Lekwungen people.
Thank you. And Anne McFarlane.
Good morning. It's still morning. I'm Anne McFarlane. I'm here from Saanich, British Columbia.
Thank you. And that's the board of directors, and the 13 of us provide that service of strategic direction and holding management to account. The members of the board, you'll notice throughout Graham's presentation, at the end of each main segment, there will be an opportunity for us, the board members, to ask questions. And I invite you to do so, and I will as well, and raise your hand. I'll be watching for raised hands if something comes to mind you'd like to question Graham on. Next, I'd like to introduce our executive management team who are responsible for the management of the organization. Voici maintenant l'équipe de la haute direction. And I'm just going to introduce them and they will wave in the interest of time. First, Dr. Graham Scher, Chief Executive Officer. Jean-Paul Bédard, Vice-Président Produits Plasmatiques. Judy Leach Bennett, Vice President, General Counsel, and Chief Risk Officer. Christian Choquet, Vice-Président Qualité et Affaires Réglementaires. Ralph Michaelis, Chief Information Officer. Andrew Pateman, Vice President, People, Culture, and Performance. Dr. Chantal Hambron and Dr. Tanya Petrasco, who have been acting as co-vice presidents of medical affairs and innovation since last fall, and thank you for that. I want to pause here for just a moment to acknowledge that Chantal and Tanya's hard work and the exceptional way in which they temporarily and with great collaboration stepped in to fill the role of Dr. Israel Levy. Dr. Levy is here today as well, and he'll be resuming his role as Vice President, Medical Affairs and Innovation on July 1st. Next is Pauline Port, Chief Financial Officer and Vice President, Corporate Services. Then Rick Prinzen, Chief Supply Chain Officer and Vice President, Donor Relations. Et dernièrement, alphabétique.
Last but not least, in alphabetical order, Ron Vezina, Vice President, Public Affairs. On behalf of all my colleagues, I would like to welcome you, the public, to this open board meeting.
And thank you very much for joining us today. So the first order of business is to go through the agenda. And of course, my cell phone is ringing just as this starts. The agenda, can I have a motion to approve the agenda if someone would raise their hand? Seeing none, I'm going to propose Ray and Bob, you're seconding. Thank you. Does anyone have a problem with the agenda or anything they want to add to the agenda? Seeing none, if no one's opposed, I'll approve the agenda. Again, declarations of conflict of interest. I will just note that if at any time during the course of the meeting, any of the board members feel that they face a conflict, they should not hesitate to so indicate. And let me just call now if anyone identifies a conflict of interest that they see on the agenda. Seeing none, let me then turn to every board meeting. We have a patient or other participant story that reminds us why we're doing what we're doing, and that is to get to deal with the public in a way that provides blood and blood products and stem cells and organs and tissues to patients who need it. And this week is National Blood Donor Week. And while it takes all kinds of donors to keep Canada's lifelines strong, we want to shed particularly bright light this week on our blood donors. To help us do that today, we have some guest speakers joining us, and I'm pleased to introduce you to accueillons Munira Premji. Munira has an incredible story to share, and it's especially impactful given that it's National Blood Donor Week. Her life-saving journey began with blood donors. Munira, thanks for being here. Over to you.
Great. Thank you so very much for the invitation to speak today. And what I want to do is to share with you a story of a day in my life that talks to the impact of blood in my life. It was March 8th, 2012. I was at Princess Margaret Hospital on the second floor in Dr. Roger Tiedeman's clinic. Dr. Tiedemann is my oncologist. He was going to give me the all clear to start chemotherapy the very next day. You see, a month before, I had been diagnosed with 2 blood cancers, non-Hodgkin lymphoma and multiple myeloma. I was fatigued and anxious to begin treatment. When Dr. Tiedemann looked at my blood results, he did a double take, and I saw his face turn white. He wondered aloud if there was a mistake in the results staring at him. When he confirmed that the blood results were correct, he immediately arranged to have me put on oxygen and ordered an ambulance to take me across the street to the Toronto General Hospital Emergency Department. When I got to emergency, I was rushed off to a curtained room and seen by 2 doctors. Next thing I know, I was surrounded by nurses and technicians. They took my vitals. They drew vial upon vial of blood. They checked my blood pressure while constantly asking me how I was doing. My husband, Naguib, and my kids, Shane and Sabrina, were hovering around my bed, looking a bit worried at the frantic pace of activity. If you've ever experienced a visit in the emergency department of a major hospital, you know that things can move painfully slowly. But here I was, the center of attention, all hands on deck. A little while later, I heard the emergency doctor having a heated conversation on the phone about the patient in bed 9 beside me. The woman was in critical condition, and he was concerned that her organs would shut down one by one if they did not begin a blood transfusion right away. The person on the other side of the phone was really pushing back. And at one point, the doctor exclaimed, "She is my patient. We can't wait for cross-checks, and I'm making the call to start blood transfusions right away. If we don't start right now, she will die." Our sympathies reached out to this woman in bed 9 beside me, until the doctor corrected himself and said, "Oh, sorry, not bed 9, bed 8. She is in critical condition." That moment is seared in my memory forever. I was the patient in bed 8. And the thought hit me like a ton of bricks. I am going to die today at Toronto General Hospital in bed 8. My hemoglobin had dropped to a fatal 36. For a woman, normal hemoglobin is around 120 to 160, and anything below 50 is concerning. I was between life and death, not quite alive and not quite dead. I could see it in the faces of the doctor and my family. As I learned later, there was a nuclear war going on inside my body. My red blood cells were dying because of a failing bone marrow function, and an army of antibodies had built up in response to the blood transfusions I had received a few weeks before. An imperfect blood match would cause my immune system to attack the new blood cells, a condition known as acute hyperhemolytic anemia. I was wheeled to the ICU. The doctors explained that they would transfuse me with 4 units of blood, but this blood had not been fully cross-checked against mine because there was no time. That was the argument that the emerged doctor was having on the phone with the blood bank, who wanted to do a full cross-check before I was transfused. Time was of the essence, and every moment mattered. They explained to my family that the first few minutes of each transfusion would be critical because my body would either accept or reject the blood. I asked them what plan B was if my body rejected the blood, and they shook their head and said, steroids until we figure out what to do. That's when I realized there was no plan B. Against all odds, I am here today, alive. Since that fateful day, I have had many more blood transfusions. I've had transfusions to boost my hemoglobin to a safe level before chemotherapy. I've had blood and platelet transfusions after 2 stem cell transplants. You know, the truth is, I am alive today because of the generosity of people who donate blood. I am alive today because of your organization that provides these life-saving products and services to people like me. And if there is one message I want to leave with you today, it is that the work you do matters. Your leadership matters as a board and as an executive management team. And I really hope that you feel that every day that you come to work, with every fiber of your being, with every cell in your body.
Wow. Thank you, Munira. That is a great reminder of why we're here. And all I can say is that your determination and commitment is a model for us all. And I'm struck by the sign you have, or the poster you have behind you, I will survive. And my sense is you've got that going for you. All the best in the future, and we wish you really good health. Je profite de la Semaine nationale du sang de...
I'll take the opportunity of this National Blood Donors Week to thank all of our donors.
We didn't know how our donors would respond. We've been grateful that because of committed donors who've kept their appointments throughout this trying year, we've been able to continue to be there when patients needed us. Merci encore à toutes les personnes.
So I want to thank sincerely all blood donors.
Board of the chair. We've been saying it, you know, I hate using this term unprecedented, but we've been saying it for over a year now. As COVID-19 has progressed, so too have the new circumstances that have made this time, our unprecedented time in our world and in our work. Challenges both new and old have affected our work since our last open board meeting. But Canadian Blood Services and our employees have remained adaptable and resilient in response to each wave of change that has come our way this year. As we spoke about in December, Canadian Blood Services contributed toward the national research effort working toward a better understanding of COVID-19. Our support of the seroprevalence study was hugely impactful and proved our value added to the Canadian healthcare system beyond the scope of our typical work. With incredible efficiency, Canadian Blood Services established a brand new lab and tested over 17,000 blood samples within a single month. This contributed toward an invaluable knowledge base for Canada's Immunity Task Force, which helped inform our country's response to this catastrophic virus, as well as which populations were being most severely affected. This was a new area of work for Canadian Blood Services with a novel sense of urgency behind it, proving our agility as an organization and ability to leverage our infrastructure and expertise when needed. In addition, the convalescent plasma research we participated in demonstrated our ability to target specific groups of donors and contribute to the successful research conducted to better understand whether convalescent plasma was a useful treatment for COVID-19 patients. Chapeau aux équipes de recherche et aux généreux donneurs qui ont participé à cette étude.
Great. Big thank you to the donors and those who helped us with this research.
Supply chain challenges were just one part of our pandemic challenges. Travel restrictions also disrupted our business in enormous and in numerous ways. But much like the demonstration of our successful research capabilities mentioned above, the pandemic had other positive ripple effects that we might not have otherwise achieved with such efficiency. Due to the inability of folks to travel safely, our Organs and Tissues program was able to expedite a long-time goal of transporting kidneys from living donors rather than having to rely on a donor traveling to undergo surgery in the hometown of the recipient in need. Being able to transport organs, as opposed to asking living donors to travel, is an enormous leap in the right direction for the efficiency, safety, and success of our living donor program. The pandemic moved this forward more expeditiously than we might have otherwise been able to. Let me talk about plasma for a minute. As well as new contributions toward the national COVID-19 knowledge base, Canadian Blood Services continue to work on our pre-pandemic key focus areas. One of the most urgent concerns being our domestic supply of plasma for immunoglobulin. Graham will speak in greater detail about this in his presentation, but the highlights include our effort to proactively procure IG on the international market. This was done to address immediate risks of shortages due to COVID-19 impacts on global supply of this vital and increasingly in demand plasma product. This was a large undertaking, made more difficult by the pandemic. But the health of our patients is the ultimate priority in all that we do, and teams work tirelessly to secure needed supply. One of our main goals in the plasma space continues to be securing a long-term domestic supply of plasma for immunoglobulin. The pandemic brought into relief many learnings, one of which was the risk of relying on international supply chains. This is particularly true for plasma. Despite the impacts of COVID-19, Canadian Blood Services has been able to keep the schedules on track for increased plasma collection. The Sudbury Plasma Donor Center launched in August 2020. Lethbridge opened in December 2020, and the Kelowna site is open this month. These three sites, however, will only hold Canada's sufficiency at current levels, and more needs to be done. And Graham will talk about this in a moment. To this end, Canadian Blood Services provided governments with a plan for 8 additional plasma collection sites. In April, the federal government, not one of our members, but the federal government announced $20 million in funding to support this plan, with the first 2 sites planned for opening in the 2021-2022 fiscal year in Brampton and Ottawa, and a third planned for opening in 2022 in Winnipeg. We appreciate this recognition and support from federal, provincial, and territorial governments as we work to increase Canada's self-sufficiency to at least 50% as quickly as possible, and to ensure a domestic end-to-end supply chain of immunoglobulin in this country. Let me talk for a minute about MSM, men who have sex with men, plasma donor changes. Another element of our work in plasma collections that I'd like to highlight is a move to a behavior-based screening model for men who have sex with men to be able to donate source plasma, rather than the deferral period of 3 months, which we require for MSM whole blood donors. One incremental step, and it's only a step, in the right direction is the submission Canadian Blood Services made to Health Canada last month, which is currently under review. This is the first time that Canadian Blood Services has had the evidence and support needed to seek regulatory approval to use screening questions that focus on high-risk activities for men who have sex with men. If approved, this will help establish alternative behavior-based screening processes that would enable men who have sex with men to donate source plasma. We're hoping to implement this incremental change in our screening processes for source plasma donors by the fall of 2021 at 2 of our collection sites, if Health Canada approves our proposal. We look forward to monitoring this new process, and we are also committed to our goal of moving to a sexual behavior-based screening model for all donors. Let me talk for a minute about mental health. La Société Canadienne du Sang a connu de nombreux succès.
The Canadian Blood Society has met with a number of successes in a number of areas in which it is active.
In the mental health and wellness of employees. Challenges facing remote workers as well as frontline workers have been incessant. Changing public health direction on personal protective equipment, differing access to vaccines from province to territory, work-life balance, and demanding homeschooling needs have plagued our organization like most organizations in the world this year. We implemented many new safety nets to ensure the financial stability and to help support the mental wellness of our employees, regardless of COVID-related leave requirements. This included caregiver leave, quarantine leave, and sick leave. Creating a work environment that supported the psychological safety of all employees in the face of pandemic-related stress has been an ongoing priority for the organization that will continue to be so in the years ahead. And the board has taken the time to deal with mental health of our employees consistently over the course of the pandemic. Our employees are playing an essential roles in the life-to-life continuum between donors and patients. Munira's story is merely a critical example of that. I know I speak on behalf of the whole board, and no doubt people across the nation, in thanking our teams for their commitment, their passion, and their service to keep Canada's lifeline strong. Merci de ce que vous faites pour la chaîne de vie du Canada.
Thank you very much for all you do for Canada's Lifeline.
For a plant worker or whatever you do for CBS, thank you. I would also like to recognize our government partners. When Canadian Blood Services national operations faced considerable challenges in the early phases of the pandemic, we worked with government officials who responded swiftly to help keep us able to deliver blood and blood products to every patient when they needed it, right across the country. Before I invite Graham to deliver his report, I wanted to touch on the importance of our open board meetings. These meetings provide the board with the opportunity to interact directly with Canadians, and we truly do see this as a privilege. Munira has just given us inspiration about why we bother. The openness of these board meetings goes back to one of the principles identified in the Crever report on the blood system, tabled in 1997. The virtual setting of our meeting allows us to once again host an open question and answer session for members of the public as part of today's proceedings. If you're watching the webcast, please feel free to submit a question and we'll address as many questions as we can in the half hour that we've designated for those open questions. C'est pour vous l'occasion de vous faire entendre.
This is your opportunity to be heard.
Meetings, we have also set aside a block of time to hear from some stakeholders who have formally registered to present to the board. And this is an opportunity for us to learn from you, to better understand the issues that matter most to you. Ce que nous apprenons pendant ces réunions alimente.
And what we learn during these presentations improves our responses.
Following the Q&A session for about an hour, and during this time, individuals or a representative from a group will have 5 minutes each to address the board. And I ask you, out of respect for your other presenters, to please stick to the 5 minutes. So thanks again to everyone for being with us here today. And we'll now proceed with the next agenda item, which is the CEO's report. Dr. Scher, over to you.
Thank you very much, Mel. Thanks, members of the board, and of course to all watching this public board meeting and presentation. Thanks for being with us. I'll just make a couple of very quick introductory remarks. So I am here actually in the atrium of our head office with some technical folk, but they are very far distanced from me, and that's the reason I'm not wearing my mask, and it's in compliance with public health guidance. I also, Mel, would like to, as you did, acknowledge the power of Munira's words. Many of us don't need a reminder why we come into work every day, but boy, did we only get it today, and that was fantastic. So thank you, Munira, for taking the time to be with us and to share your profound story. And as you did, Mel, I will also acknowledge, of course, that this board meeting is being held during National Blood Donor Week, which is a really important week for our industry. As I do at this time every year, the intent is to walk the board and members of the public through a comprehensive review of the organization's performance for the past year, so our fiscal year 2020 through 2021. And I intend covering some major achievements, a review of the operational performance for the year, the strategic performance and review against our corporate strategy. And at the end, as we always do, is also give a financial review of our performance for the past year. Mel, I'm going to rely on you to obviously just jump in. I can't see hands up on a screen here. So just to jump in and let me know there's a question. But we've also built some slides in the deck just to pause at certain points. But please, board members, feel free to jump in at any time. So what's the takeaway message? I think this slide really delivers it, that if I think about 2020, 2021 on a single 30-second elevator ride, it's probably this, that we did meet customer needs throughout the pandemic, despite a very volatile environment, and I'll unpack that in a sec. We have lots of evidence to show that we maintained a state of control on all of our critical indicators, and I'll point to those.
Can I just pause you and ask Baldwin to make sure that the slide is coming through? I'm not getting it.
Can I just see a hand from anyone else? Are you seeing the first slide continue to build on success? No, so I'm just, okay, they're fixing that. Mel, do you have the slide now?
Now we've got it.
Oh,
carry on.
Apologies.
Sorry for that.
No, that's good. I want you to see the data. We're going to do this in real time. So as I said, met demand despite volatility, maintained a state of control. I will talk, as you did in your introductory remarks, Mel, on our work to accelerate plasma security of supply. I want to talk at some length about the important work we've done to both support this organization through the pandemic and support the country in a broader fashion. And then we'll talk as well about the importance of keeping our employees, donors, volunteers, contractors, anyone who we interact with well, both physically and from a mental health point of view. All right, so let's dig into the operations review. And the first line of business, of course, is our fresh blood products business. So I want to sort of unpack some of the achievements of the past year. As I said, despite significant volatility in supply and demand, particularly in the first few months of the pandemic, we were able to consistently meet hospital needs and have been able to do that throughout the year. But it did require a degree of agility on our part in managing the collections plan, bringing donors in and collecting blood, and the supply plan, so delivering to hospitals as their situations became very volatile in the pandemic. One of the things we had to do was to shift a lot of our collection environment from our mobile blood centers into our permanent centers. And there were multiple reasons for that, not least of which is in the early months of the pandemic, a lot of the locations that we would typically go to collect blood on a mobile clinic were not available to us. They were all being shut down as part of the early public health measures. And we found we were able to achieve a higher state of control in our fixed permanent collection sites. We could ensure physical distancing, we could build the protocols in and keep them consistent. And so we migrated a lot of our collections from the mobile environment to the permanent collection environment. And today, just about 70% plus of our collections are coming from our fixed donor centers. As I said, we had to remain very agile and responsive to the ebb and flow of demand and supply. And I have an interesting chart that I'll show in a minute on that. And the medical group and operations group inside Canadian Blood Services worked very closely with the National Emergency Blood Management Committee. This is a committee comprising not just CBS folk, but colleagues from the hospital environment, physicians, blood bank technologists, folk from our provincial ministries of health and others who collectively come together and really advise on what the system needs, particularly in volatile times. This is an interesting slide, and it's really just meant to demonstrate a graphic. I don't want you to look at the detail on the bars, but the red line basically shows the inventory of blood, red blood cells that we had over the past year. And the gray bars at the bottom are really bars that match supply and demand, either the demand from hospitals or the amount of blood that we collected. And as you can see towards the left-hand side of the slide where the gray bars have a little bit of a dip, that was the early months of the pandemic, March, April, May, when the demand began to plummet, our collections began to plummet. But actually, we were able to stay ahead of the game. We had more collections than we had demand, and you can actually see our inventory rose dramatically. And that turned around pretty quickly in sort of the second quarter of the pandemic, so sort of May, June, July timeframe. You can see what happened is exactly the opposite. The acute care sector got a little bit under control. Surgeries resumed after the first wave of the pandemic. The demand suddenly went up, and we had to bring donors in again to catch up to demand. And so you can see our inventory dipped a little bit, but then it's been able to be maintained at an extremely healthy level for the rest of the year. And so we really are running a stable and healthy inventory now, but as the board well knows, not without a lot of effort on the part of our supply chain and our medical folk. This is a chart that I use on a regular basis, and the measure we use here is called order fill rates, which is basically when a hospital orders blood from Canadian Blood Services, can we fulfill that order first time it comes into us? You can see for the various product types there, we have a target, and the bottom line is for all of 2020, 2021, we essentially exceeded that target. And the one I would simply point out is Group O negative red blood cells, which is always the most challenging component to have adequate supplies of, because it's the one that is in highest demand at all times. And you can see we had a remarkable performance this year, essentially delivering 100% against the target. And that's really important, because I would say that that's probably the highest level of performance for Group O negative red cells in our history. And that is as a consequence of many of the programs we've put in place, both to recruit O negative donors and to make sure we can match our collections supply with the demand from hospitals. This chart on the one hand looks like a little bit of an eyesore, but I want to use it to demonstrate a point. The red line, the sort of wavy red line at the bottom of the chart, members of the board, is essentially the case count, the average weekly case count of COVID-19 cases for the past year. And you can see wave 1, wave 2, and wave 3 of the pandemic, where you see more and more cases being diagnosed in Canada. The blue line is essentially the average amount of blood we issue to hospitals on a weekly basis. And the telling story is that in wave 1 of the pandemic, the demand plummeted. It literally fell through the floorboards. And the reason for that is in the first wave of the pandemic, hospitals did not know if they were going to be able to cope with surgery and cancer care. And pretty much every province in the country dramatically reduced the amount of care being delivered in hospitals in order to protect capacity for sick COVID-19 patients. In the subsequent waves, even wave 2 and wave 3 in particular, when the number of cases being diagnosed in the country was much, much higher, by then the health system had stabilized a little bit. And despite lots of pressures on emergency room and ICU beds, the amount of care being delivered in hospitals moderated, and we were able to generally both bring donors in and largely meet supply, despite a very, very high case count in the public of COVID-19 infections. The next few slides are slides that I've used many times before. The board will be familiar with them. And it's just essentially on the left-hand side of the chart is the 5-year trend, what has been the trend of the past 5 years. And the right-hand slide is the sort of expanded data for the fiscal year that I'm reporting on. This is red blood cell shipments and collections. The red line is the collection numbers. The green bars is our shipments to hospitals. And as we've talked many times with the board before, the demand for red blood cells has trickled down slowly in Canada over the last 5 years. This is not unique to Canada. It's a phenomenon being seen around most of the developed world, where the demand for red cells has gone down slowly, about 1 to 2% per year, as medical interventions improve and surgeons and physicians have different ways of blood-sparing medical care. You can see what happened in the first quarter of 2020, 2021, the left-hand part of the right chart. You can see a very low amount of shipments to hospitals, and that was because of those early months of the pandemic. And you can see our collections were also low then, but nonetheless ahead of our shipments. For the latter part of the fiscal year, things are somewhat more stabilized and normalized. We also measure, as the board knows, manage and measure not only the inventory, but how much blood actually gets discarded in our system. And it could be discarded because it doesn't meet quality purposes. It fails on a test, that a donor has a positive test, we can't use the unit, or something goes wrong in the manufacturing process and the unit is deemed unacceptable, or it may outdate on our shelf. And obviously, our objective is to minimize the amount of outdates. The left-hand side of the chart just shows that over the past 5 years, the discard rate, which is the red line there, had been fairly static at around 6%. And you can see on the right-hand side, the first quarter of the pandemic, we saw the discard rate double almost to just over 9%. And the reason for that is we had that very, very high inventory, very low demand, and we were actually outdating units at a much higher rate than normal. And you can see that pretty quickly normalized through the rest of the pandemic period. This slide is platelet data, and it's a somewhat stable story both for the past 5 years and this fiscal year. The impact on platelets from the pandemic was much less than the impact on red cells. Platelets are typically used for cancer patients, cardiac surgery patients, some other patients with bleeding disorders, and we've really been able to keep the platelet collections, whether they derive from whole blood, what we call our pooled platelets, or from the specialized collection machines, the apheresis platelets. We've been able to keep those numbers pretty stable for the past few years, and we're able to keep them stable throughout the pandemic. This slide has a lot of numbers, but it's a very important one. We report it to the board twice a year, and this is the year-end data for safety and surveillance for some, and this is just some of the important pathogens that we measure. As the Safety Research and Ethics Committee that Anne chairs knows, you get a whole report of multiple pages that provides a lot more data than this, and you oversee that report at the Safety Research and Ethics Committee. But this is the sort of takeaway message. For this past year, you can see that our number of detected positives in donors for HIV, hepatitis C, and hepatitis B, 3 of the important viruses we measure for, you can see that they were very low and in keeping with previous year's numbers. The one number that might jump up to you is that it looks like we had 0 detected donors for HIV in last fiscal year. That is true, but already in this fiscal year, we have detected one positive for an HIV infection in a donor, and this happens every year. We detect usually a very small number, often in a first-time donor and much less often in a repeat donor. The takeaway message here, the residual risk, those numbers shown at the bottom of the chart, remains extremely low, and the blood supply in Canada remains extremely safe as a consequence of the plethora of screening questions, donor protection measures, testing, and other processes we put in place, and I'll talk some more about that as we go on. Of course, we also monitor, measure, and test for other things. West Nile virus is something we've been paying very careful attention to in Canada for about 18 years now. And you can see in the past year, we were able to interdict 12 positive blood donors who we screened, who were screened positive for West Nile virus. And of course, their blood does not make it through the production process and is not used for patients. This is a number that jumps around every year. It can be anywhere between 6 and 75 West Nile virus positive donors a year. So 12 for last year was sort of reasonably consistent with previous years. The board, and particularly the SREC committee, knows we are doing a lot of surveillance on a number of pathogens, not just Babesia and hepatitis E, but I want to call these two out because they are two pathogens that are getting a lot of attention, not just by us here in Canada, Canadian Blood Services, but blood operators around the world are paying very careful attention to these parasites. And at the moment, the data would suggest that the risk in Canada is exceedingly low for both of these, and no requirement to introduce any additional measures above and beyond the ones we have. So I'll jump from blood very quickly into the other major product. This is our plasma protein and related products, part of our business. And a few sort of takeaway messages here, some of them process-oriented, and then I'll show you some data on the products. As the board knows, we've been working with the Canadian Agency for Drugs and Technology in Health, CADTH, as well as with the PT Ministries of Health, to modernize the process by which products are deemed to go through an evaluation and then deemed suitable to be carried on our formulary. So we call it the CBS CADTH interim process. It's been agreed to by all the Deputy Ministers of Health in the provinces and territories, and I'll show you a couple of important steps that went through that process for the first time this past year. In the early months of the pandemic, as the board knows, we organized home delivery for some of the plasma-related products, meaning that patients, particularly those with immune disorders, did not need to come into hospitals or hospital pharmacies to pick up their products. And where we were able to support hospitals and provinces, we delivered some of this product direct to patient home. Of course, the board knows, and we've talked about this at great length at every board meeting, one of our major focuses continues to be the security of supply of immunoglobulin products. And as I've reported before many times, the global pandemic had a dramatic impact both on plasma collection around the globe, as well as manufacturing capacity in the companies that make immunoglobulin. And so we had to manage some very, very challenging and disruptive concerns around access to immunoglobulin products for Canadian patients. And as I'll show you later on in the financial data, one of the things that we did was actually procure significantly increased volumes of IG from our suppliers beyond that which we were contracted to with them to purchase. And we did that in order to assure security of supply for patients for this critical product that was and remains in high risk of potential shortages around the world. We continue to work with the National Emergency Blood Management Committee, with hospitals, with providers to make sure that the brands of the products we have are able to be used nimbly for the various patient groups. A lot of words on this slide here. The takeaway message is that for two drugs, emicizumab, which is a novel drug to treat patients with hemophilia A, we put this drug with the approval of the provinces through that interim process that I referred to, the CBS CADTH process, and it came out of that process with a positive review, meaning based on both the medical scientific review that we had done, the health economic review that the experts at CADTH had done, there was a positive review to add this novel therapy onto our formulary for hemophilia patients without inhibitors. We had previously been carrying it only for a small group of patients who have inhibitors to the protein that is missing in hemophilia A, factor VIII. This was a major step forward, and that product is now available to hemophilia A patients without inhibitors. We're managing the process by which we deliver it to patients on a named patient basis, but a very, very significant step forward and a dramatic improvement in the care for hemophilia patients. There is a second drug that we hoped to put through the process. It's also a drug for a bleeding disorder called von Willebrand's disease. This is a drug that goes by the name Vonvendi. We were ready to put it through the process, and then the manufacturer advised us that they would actually not be bringing this product to Canada, at least for the foreseeable few years, the next few years, and so it did not go through the process. That is now being communicated to affected stakeholders, to prescribers and patients who are hoping to see this product added to our formulary. And we'll continue to work with the manufacturer to see when they have the ability or the interest to bring it back for evaluation in Canada. The next couple of slides are just the same pattern. It shows you the last 5 years on the left-hand side of the slide, in the current fiscal year that we're reporting for on the right-hand side of the slide. This is the immunoglobulin category of products. And of course, you can see in the green and gray bars, the average 6 to 8% increase year over year in the use of these products, with a flattening in 2020, 2021, driven mostly by a reduction in use in the first quarter, which you can see in the red-gray bar. And the reason we're seeing a slight flattening in the demand for immunoglobulin is probably several-fold. One is a lot of patients got excess product from us in the early weeks of the pandemic, so that would have been reflected sort of in the last few weeks of 2020, 2021. But also the number of patients who are getting this product, either the treatment that they're getting it for, whether it's to support their cancer care or as part of other ways of treating some of these patients. Some less care has been, some less treatment procedures have been used for some of these patients. So we're seeing a flattening in demand. But I think a lot of the credit actually goes to the work that the physician prescribers are doing, the ministries of health are doing in collaboration with the CBS subject matter experts. There's been a tremendous amount of work this past year to try to optimize utilization of this product. And I think we can see some of the benefits of that program in that we've had not a reduction in use, but a slowing down of the rate of increase in use. So instead of seeing the 6 to 8% year-over-year growth, it's essentially pretty much flatlined for this year compared to the prior. This is the drug to treat hemophilia A, factor VIII concentrates. A somewhat similar story. It looks like at the 2021 year, there was a reduction in demand, but what we think is happening is that patients were simply getting product brought into their homes so that in the early weeks of the pandemic, and that sort of seemed to suggest that demand went down slightly in the first quarter of 2020, 2021, but essentially the use of the hemophilia A drug, factor VIII, remains more or less consistent year over year.
Graham,
this is an interest.
Graham, if I could just intervene, Craig Knight has a question for you from BC.
Yes, correct. Graham, you were talking about our supply of blood and success with our collection. So just curious, were we called upon during the pandemic by any other country who was in need of blood, who asked if we could share from our supply? Did we get asked to do that by anyone from another country?
We did not get asked by any other country, Craig, to provide red blood cells or other products. But I can tell you that we were working very, very closely with our sister organizations from the Alliance of Blood Organizations. So that's Australia, England, the Netherlands, and major blood operators in the United States. We were in constant communication with them. Each was trying to understand what we were all seeing from a supply-demand volatility. And I think it's fair to say that the patterns that I showed you here were very similar in pretty much all of those countries and those major blood systems. It's interesting, though, and this is public data, so I'm not disclosing anything that I shouldn't be, but the Australian blood system at the moment is actually having some challenges with inventory. So when I'm showing you, we have very, very solid inventory. They're having some challenges trying to ensure they have adequate collections to meet demand. They had a somewhat different pattern of the pandemic in Australia than we did in North America. We've been in close contact with colleagues in the UK and the US. So no call on us to provide blood, but an observation that this volatility that we were seeing was reasonably similarly reflected in most other blood providers.
Jeff Scott has a question too.
Graham, it's unfortunate Bon Bendy that they're delaying coming to Canada. Do we know any reason? Is it a business situation, or hopefully it's not an issue with the effectiveness of the product? I'm just wondering if there's any knowledge about that.
Yeah, no, I don't believe it has to do anything from a safety or efficacy point of view. Jeff, it's a licensed therapy, and I think the regulators have done all the due diligence. I do believe this is a business decision on the part of the manufacturer, and obviously they're seeking to identify which markets they have sufficient volumes to bring the product to. Oh, and we'll stay very close to the manufacturer to see when they seek to bring it into Canada.
Okay, thank you.
Okay.
I was just.
Oh, sorry, Glenda has a question. Sorry, Glenda Yates.
Thanks. Graham, with this volatile demand situation that we've seen, and with the understanding that we're going to have a lot of pent-up demand for surgeries post-pandemic, whenever that turns out to be that we can resume and deal with some of the things that our customers have had to put off in terms of serving patients. How are we connecting to try to make sure that going forward, we continue to understand what the demand for our products will be?
Yeah, thank you for asking that. That is such an important issue because I think the really important thing for all of us at CBS and obviously our customers and even the public to appreciate is there's a very high level of uncertainty as to what the future might look like. We know from direct communication with our major customer hospitals, from our daily interactions with ministries of health, from experts on the National Advisory Committee for Blood and Blood Products, we know that there is this pent-up demand for major surgery and for cancer care principally, but probably for other medical interventions as well, that the hospital sector, the acute care sector, is now seeking to catch up on as hopefully we all emerge out of the third wave and we don't have another major wave of the pandemic coming our way. So we're seeing announcements from ministries of health and from health authorities and hospitals that they're anticipating a significant surge, both on the elective surgical basis as well as on delayed cancer care. And of course, those are the major patient groups that use both red blood cells and platelets. So we're staying very close to this. We are seeing literally as we speak right now, a slight uptick in the demand for red blood cells, a couple of percentage points, certainly not dramatic, but a number of other countries are seeing a very significant uptick. So it's something we need to monitor very carefully. And I guess the primary answer to your question, Glenda, is we have made sure that we've built agility into our planning protocols and our ability to scale collections up should we see some of those demand surges, either for cancer care or surgical care. One of the things that we hear from a number of health leaders, both on the medical side and the administrative side, is that it is possible that most of the blood using surgeries happened during the pandemic period, whereas it's the more elective and less blood demanding surgeries that were the ones that got backlogged. We don't know how precise that information is, and so we have to anticipate that this pent-up demand, as you describe it, will need to be met for months to come. This is not going to be resolved in a matter of weeks. This is probably with us for 12 to longer months as health systems seek to regain lost capacity. So I think it's something we're very attuned to. Our surveillance and sensing mechanisms are sort of really revved up and operating on an agile basis. And I'm confident that we'll be able to adjust our collections plan to meet any shifts in demand patterns.
Press on, Graham.
Thanks, Mr. Chair. On this one, it's just one of the drugs we've reported on often. This is a class of drugs called C1 esterase inhibitors. And one of the stories on this drug, if you look on the left-hand chart, you can sort of see almost a 20 to 30% growth year over year, and then suddenly a flat line in this past year, essentially no growth compared to the prior. So a very, very different pattern of use of this drug. There are a number of reasons for this. There have been some differences in provisioning practices. We do think the pandemic has resulted in some fewer procedures that that patients who have this underlying condition will typically get preventive therapy with, if they, for example, going to have major dental procedures or something. So there may have been some delayed use impact there. But one of the major drivers here is that there is a new drug within this class of drugs that is now actually carried on provincial drug formularies, not the CBS national formulary. So we're seeing a little bit of a re-equilibration of what comes out of our formulary versus total use in the country. I'll do a very quick summary, Mr. Chair, of stem cells. A very interesting narrative during the pandemic. The demand for cord blood stem cell products is the highest it's ever been since the inception of our program. I'll show you that on a slide. One of the biggest challenges we had was actually bringing stem cell donors in so that we could take a swab from them, do the necessary tests, and register them on our stem cell registry. And the reason for that is most of our recruitment efforts prior to the pandemic were done in person in large events. So as you can imagine, of course, that all disappeared, and we had to recruit donors in different ways, which put a very, very significant challenge on us. We are relying more on digital tools now to recruit donors rather than these in-person tools. And one of the major achievements this past year is that the head of our stem cell program, Dr. Heidi El-Moazen, is part of a large consortium of physician scientists in Canada who were awarded a Canadian Foundation for Innovation grant, the Accelerate grant, and we're a collaborator in that large national research program. Just some numbers on this in the next slide. I think the take-home message I would leave the board with is on the right-hand side. You can see that the number of stem cell transplants in 2020, 2021 was no different than prior years. So even despite some of the challenges of delivering care in hospitals during the pandemic, to a large extent, stem cell transplants were reasonably unaffected. This is the slide that I wanted to call out the use of cord blood as a source of stem cell products. And on the right-hand side of the chart, you can see that we provided 19 cord blood units into the transplant systems around the world, either an international patient or a Canadian patient. And of course, the board will remember this is the one program where products are moved around the world. So our cord blood bank sort of stepped up and did more than double the activity of any prior year. And we think one of the reasons for this is physicians who were doing transplants for their patients were relying more on cord blood units because you can control the timing of that. You're ordering a unit that's coming out of a freezer, as opposed to identifying an adult donor who you have to find, bring into a center, put them through a variety of tests, and then collect the stem cell product from them. So there was a move away from doing that in the early months of the pandemic and relying on units that are banked in freezers. Interestingly, autologous transplants, so this is a transplant where we do some work to support the transplant centers. all an autologous transplant means is the donor and the patient are the same person. So I have the underlying disease, I go into remission, my stem cells get collected, and then after chemotherapy, I get my stem cells back. We do some work to support some of those programs, and you can see that the pandemic had quite a big impact. Fewer autologous transplants were done this past year than in previous years. The story on organ donation and transplantation was quite dramatic. The pandemic really hit the solid organ transplant world quite hard, and I'll show you some data in that regard. The one program that we run is the kidney paired donation program, which is where an individual, a live donor, a living donor is identified who can be a kidney donor for somebody who is unrelated to them through this sort of chain process that we manage. And that program was actually shut down for 8 weeks at the first phase of the pandemic because people did not really want to bring potential donors in at a time when we didn't know what the impact of the pandemic was going to be. So, and as Mel actually mentioned in his opening remarks, there is some good news on this one. Rather than moving people around, donors to transplant centers, we were able to collect kidneys from donors in their local communities. And then we worked with Air Canada to develop and institute a program where kidneys are actually now shipped across the country. There's a lot of numbers on this slide. The take-home message is whether the donor was a deceased organ donor or a living organ donor, right across the board, the number of donations of solid organs went down across the country. Hearts, livers, lungs, kidneys, living or deceased. They went down as a result of the impact of the pandemic. As a result, you can see on this slide here, in the very early months of the pandemic, a dramatic reduction in April, May, and even June, began to normalize a little bit, but at no period in the last year did it match numbers from a previous year. And as a consequence, the number of transplants went down, fewer organ donors, fewer transplants. And of course, this has had a dramatic impact on care. And it's one of the things, to Glenda's point, where we know there is going to be pent-up demand for people who are now continuing to live with end-stage organ failure, you know, the desire on their transplant physicians and surgeons to get their transplant happening. As I said, the kidney paired donation program, the red bars, dramatic reduction in 2020, and we're slowly beginning to see that normalize. We
Graham,
continue
hold on. We've got Glenda, please.
Thanks, Graham. Just on this point, we always call attention to the people who are on the wait list for donation particularly during the donation, the Not Dog Week, where we try to highlight this for Canadians. Do we know anything about what this impact has been on those who are waiting for organ donation?
Yeah, I don't have the numbers at my fingertips, Glenda, but almost certainly the number of patients on the wait list as measured by the transplant centers in Canada will have gone up as a consequence of this. There is no doubt about that. Now, remember, of course, we've reported this before. There's typically around 4,200 patients on the solid organ wait list when they're counted by the different criteria that the transplant centers use. So I don't know by what percentage that number has gone up. We'll get that data and report it out. We certainly have it. But there is absolutely no doubt that solid organ transplants for different types of organs were delayed. I think one of the challenging metrics to assess, and I don't know if we have it, but we'll certainly seek to understand if our transplant colleagues have it, is did more people die waiting for an organ than would typically occur in a year? And as we know, there are about 200 or so patients on an average each year who die while waiting for a solid organ transplant because there simply isn't a donor for them. So whether that number went up in this past year, I don't know, but I'll make sure we get that data.
David Lieberg.
Graham, with a return to surgery over the coming months across the country, are there any projections on when you think we might see a return to the previous level of transplant surgery?
David, we're obviously tracking that very closely now by transplant center and by province. So I'll certainly make sure for the next board meeting, we report this out on a sort of a real-time basis. Certainly what we're hearing now is that a lot of that care is resuming. I think as ICUs have emptied out, are emptying out of patients with COVID-19 who've been occupying ICU beds and ventilators, there is going to be greater capacity for these ICUs to support patients who have solid organ transplants, because many of these patients, this is pretty big surgery, and they would go into an ICU after their surgery for a few days. So I don't have the numbers off the top of my head, but I suspect we are working with the transplant centers and projecting that out. The generic comment I would make is that every transplant center, every hospital, every health authority, and every ministry across the country are making their decisions independently as to which parts of delayed care are going to get expedited. So will it be I catch up on my cancer backlog or on my transplant backlog, and which do I do, or my neurosurgery backlog, and which do I do first, and how do I prioritize all of that? Those are decisions that are being made at the institutional level and the ministry or health authority level. And of course, we're seeking to understand that, because that will impact whether it's organs or blood demand. So we'll get some more data on that, David.
Graham, my question was going to be, actually, you've given us aggregate numbers for the system. Have we seen interprovincial differences? You've just talked about interprovincial differences on opening up, but have we seen, transplants stayed up in this province or that province?
Yes, and again, I don't have the numbers off the top of my head, but I know at our COVID-19 steering committee, we were monitoring that on a jurisdictional basis. And it is exactly true, Mel, not every province made the same decisions to curtail delivery of care. So BC at one point was maintaining delivery of acute care, while other provinces, Ontario, Manitoba, for example, were not. So it is absolutely true. There is a regional variation to the story that I'm talking about at a macro level. So and I think that is true for even demand of red cells. So yes, we can unpack that at a regional level, Mel, for sure.
Okay, carry on.
All right, I'm just going to watch the time here. So I wanted to talk about a couple of the research outputs this past year, as I do every time we deliver this presentation. So as the board knows, and we'll be talking a lot about this later this afternoon as well, we've been supporting, along with HEMA Quebec and with the support of Health Canada, have been funding a number of research projects across the country, 19 in total, all looking at a variety of opportunities to help us further evolve the donor deferral criterion for men who have sex with men. 12 of those 19 research studies have now completed. A few of the others are very near completion, expecting to be completed in the next number of weeks. There have been a number of peer-reviewed publications, and we meet on a periodic basis with the researchers undertaking these studies so that we can understand the outputs, because that will help us further evolve the policy, and I'll talk on that in a couple of minutes. Our broader research program, supported by our Research Ethics Board, has been pretty busy this past year. You can see that the Research Ethics Board reviewed more than 50 applications to support a variety of researchers in the transfusion and transplantation space, whether it's about us providing products, us providing samples, or participating in clinical trials. There's been a lot of work on the research front. We also do the knowledge creation and dissemination work, as the board knows, and I just used two examples on this slide. There's a research consortium called the Quest Research Consortium, and they're interested in understanding what patient groups or patients are at higher risk of having bad reactions to intravenous immune globulin, what might be some of the predictors of adverse reactions. So we're collaborating with the Quest group there, and we have been sort of the principal drivers and secretariat function of the International Collaborative for Transfusion Medicine Guidelines, ICTMG. CBS has sort of been the glue that has kept that program going, and they've done a lot of work focusing on optimizing and developing guidelines for platelet use in a variety of clinical settings. There's a lot of words on this slide, and I want to pause on it for a minute, not to read the slide, but just to make the point, and particularly for members of the public, throughout the pandemic, Canadian Blood Services both challenged ourselves and was asked by, in this case, the Federal COVID-19 Immunity Task Force, to see if this organization could leverage its national footprint, its expertise in testing, its infrastructure capabilities, its logistics capabilities, and other sort of capabilities that we have because we are the national blood system. And we collaborated and continue to collaborate to this day with the Federal COVID-19 Immunity Task Force. From the very outset of the pandemic, we began to collect excess samples from our donors after all of the testing was done that we have to do for blood safety, and then used some of these samples to do sequential or serial antibody testing to understand what was the prevalence of antibodies to COVID-19 in donors in various parts of the country. We've been doing this on a regular basis for the past 15 months and have committed to the Immunity Task Force that we will continue to do this through till at least March of next year, 2022. We've used two different types of tests. Before a vaccine came along, we had a test that would detect native infection. We now have a test that can distinguish between native infection and vaccination immunity. And we're continuing to produce regular reports on a quarterly basis that go to the Immunity Task Force, who is also collaborating with many other programs across the country. CBS is a very proud partner here. We've probably been by far and away the largest provider of data into the Immunity Task Force, and we are providing important public health data for the country. Some very interesting findings that we've been able to share with the task force that are now sort of being collated and used to inform public health policy. The immunity, if you want, or the presence of antibodies to COVID-19 was much higher in lower income neighborhoods, nearly 4 times higher, amongst racialized communities, almost 4 times higher. So these are really important public health findings, and it helps then public health leaders, ministries, public health units make decisions around how to certainly protect certain communities and prioritize vaccine access. In addition to that set of activities, we supported the clinical community to undertake a series of very important clinical trials looking at plasma from people who had COVID-19 and then recovered, the so-called convalescent plasma, because it was thought, based on very good evidence, that people who had recovered from COVID-19, had antibodies in their plasma, that plasma could be a therapeutic intervention for somebody who was subsequently sick with COVID-19. You could give them a plasma transfusion filled with antibodies. So there were several trials stood up in Canada. There are the names of the trials. There were trials in the UK, in the Netherlands, in the US, all over the world. And pretty much all of these trials at the end of the day showed, after running the trials, that convalescent plasma was not, in fact, having the desired or expected therapeutic benefit. So first in the UK and then very shortly thereafter in Canada, the clinical trials were terminated after the sort of interim analysis showed that no clinical benefit was happening from convalescent plasma. So some people might say, well, wow, that was a waste or that was a failed experiment. I will make exactly the opposite contention, that this is precisely why clinical trials are done, so we can understand whether the therapy is going to be effective or not. And the Canadian trials, the UK trials, and trials in Europe all confirmed that, at least for the patient groups for which CCP was being used, this was not an effective therapy.
Hang on, Graham. You're going to questions, I see. Anne McFarlane.
Hi, Graham. So I was really struck that we can do such effective zero prevalence studies and distinguish, for example, between people who are immune because of the vaccine or immune because they had COVID. I'm wondering, are there any plans to use this capability in the future, for example, surveillance about flu or anything else?
It's a really good question. And so as part of our ongoing work with the Immunity Task Force, so Chantel's group, Dr. O'Brien's group and others, there are many of these questions are out there on the table. And of course, CBS was only one provider of data into the Immunity Task Force. Many other entities were doing testing, whether provincial centers like the BC Centre for Disease Control or many other institutions were providing data. We are going to remain as part of a collaborative at the table. I think there are going to be some very important, and Isra can certainly speak to this at some length more than I, but I think there will be some very important questions asked as a country. What did this experience teach us in the pandemic, and how can it be leveraged perhaps to have better understanding of immunity for other pathogens, whether it's a flu or potentially other pathogens? The argument I would like to, not the argument, the contention I would like to keep at the table is that we were able to leverage some of the infrastructure we have as a national provider with deep expertise and capability in transmissible disease testing. And the question we're looking at internally is, should we continue to leverage that capability in a post-pandemic world for ongoing national seroprevalence of other agents? And can we be a collaborator as part of a much larger national consortium? I think that is a very important discussion for the country to have. It's not one that we alone will drive by any manner of means, but it's one that we would certainly be interested in participating in, because I think this is an example of leveraging capability and capacity.
Thanks a lot,
Kelly?
Graham, I have two questions. The first is that some people have raised concerns about accepting blood donations from people who've had vaccines. Could you comment on that?
Yeah, absolutely. And this question has come into us many times, actually. We've had numerous discussions at our COVID-19 steering committee on this. The medical team has done an extensive analysis and talked to many experts around this. And the short answer is, it is safe for somebody who's had a vaccine recently to come in and donate blood. There is absolutely no prohibition on that. And it is safe for somebody to receive that blood from somebody who's been recently vaccinated. There's sort of a lot of science that we can unpack behind that, but the short answer is a COVID-19 vaccination is not even a temporary prohibition on donating blood, and it is both safe for the recently vaccinated individual and donor, and it is safe for the recipient of that product to receive that blood. And we are addressing that question on a fairly regular basis. It comes in through our call center, it comes in on our donor centers, and we're trying to make sure that that message is consistently delivered because we certainly wouldn't want people staying away from blood donation just because of a recent vaccination. And Dr. Petrasco and her colleagues are looking at that question even across the international blood operators, but the evidence is pretty clear.
And my second question is, would you comment on the impact that COVID has had on our ability to attract new donors?
Yeah, that is there's a lot to answer there, and in the interest of time, I'll be brief. I mentioned much earlier that one of the things we found ourselves needing to do was to shift our collections into our permanent centers away from our mobile centers, just because of many of the challenges of location and not actually having access to some of the mobile locations that we would typically go to. So that had an impact because there is a differential rate on recruitment of new donors. Sometimes you're very successful at certain mobile centers to bring new donors in, and the permanent centers have a slightly different approach. So yes, we have seen the number of new or first-time donors coming into our system this past year. We did not hit that target. Again, we were able to maintain our collections. I showed you lots of data there, but we did that because we were actually relying to a higher extent than normal on our regular donors. So all of that is being evaluated now as we move forward. What is sort of the post-pandemic reality as we collect more blood from our permanent sites? How do we make sure that we continue to increase our number and meet the target for new first-time donors each year? That's really important. But I think it's fair to say the pandemic did have an impact. And maybe it's folk who were unfamiliar with what a blood donation process is, uncertain whether they would be safe in our environment, therefore chose not to make a first-time donation. Whereas those who've been regulars and understood the safety protocols we have in place felt safe coming in. So we think that that contributed in some way to that, Kelly.
Brian Postal.
Graham, I'm curious, I haven't heard any mention of, so we of course have lots of involvement with patients who have some degree of immune compromise. With mRNA vaccines, there's really no risk to them receiving the vaccine. The question is, can they mount an adequate immune response? Do we have any data on their capacity to mount the immune response, and to what level they are compromised in that respect?
Well, we wouldn't have that data, Brian. I don't know, and I don't know if I can somehow technically turn this to Chantal or Isra to answer that. I can't answer that question. I don't think we have data based on our seroprevalence because we're measuring from donors, not immunocompromised recipients.
I can give an initial response because I'm going into a study at Princess Margaret Hospital that will look at immunocompromised patients. I am one, and the reaction to the vaccine and what kind of response that lymphoma patients having had a particular rituximab as a chemotherapy will have. But as far as I know, the answer is, to this point, we don't know. But I should let the doctors respond, not me.
Yeah, but I guess we wouldn't have data to that effect. Not any of the work we've done on the seroprevalence would answer that. Chantal, can you wave your hand if you can hear me? You're on mute, Chantal.
Can you hear me?
Yeah.
Yes, now we can.
Hi there. Yes, so just to confirm what Graham is saying, that's correct. We did not, through our seroprevalence work, test out that question, Brian, which is if a person who's immune compromised received the vaccine, do they have adequate amount of antibodies? But what I will say is, in the organs and tissue donation space, we have been convening on a national scale in order to support those transplant communities that are trying to ask that question of their transplant recipients who are immune compromised. So through that work, we're looking at the evidence and supporting the community.
Thank you.
Mr. Chair, with your
you should press on.
Yeah, and I have more slides than I do time, so I'm going to be fairly brief on the strategy review. As the board knows, we're engaged very actively in looking around the corners for the future, because we recognized very early on in the pandemic, we didn't only need to manage the acute phase of the pandemic, we needed to prepare ourselves for what the post-pandemic future would look like or could look like, and how would we be optimally positioned to address that. As we've reported to the board about at some length, and so apologies to the public, I'm not going to do this enough justice, but there are three thematic areas we want to answer questions around. How do we remain agile? How do we remain resilient? And what foresight capabilities do we need? And building on those themes, we have identified three pieces of work that are going to supplement or complement our sort of strategic planning focus for the next few years. How do we build a resilient suite of products and services? What is the future of work in our environment, both physical and process related questions? And what is the future of automation and digital transformation, and how's it going to impact our work? So that's an imperfect summary to a very lot of work. I wanted to just mention in this presentation our work on developing the roadmap and beginning the implementation of pathogen inactivation technology. We've talked to the board a lot about this in the past, and as you know, we have started a phased approach to our implementation, with our first site being Ottawa. That is sort of in evolution as we speak, and our plan will be to roll out on a national basis over the next year. And this is initially for platelet pathogen inactivation, because that is essentially the only technology that it's licensed for at the moment. And we continue to look at how and what our roadmap needs to be to bring red cells and plasma into the pathogen inactivation space as well. In terms of the strategy, key focus area of the donor experience, we continue to do a tremendous amount of work with our donors to make sure that they have an excellent experience when they're with us. The one data point I'll just show you here is that the number of donors who are booking appointments through our digital channels, so the app or when they're in the collection event through the digital booking capabilities we have there or our website, is actually now north of 70%. And you can see that's been a journey we've been on for a few years. That has been our aspiration to get there, and we actually are there ahead of our anticipated target. And now it's a matter of leveraging our digital channel booking even further. Very high satisfaction scores with our donors. I wanted to show this because it gets to the question earlier around the impact of the pandemic on donors, and you can see that donors continue to be very satisfied with the experience with us. And then I'll catch my breath, and I do want to spend a minute on this slide. You did set this up in your introductory remarks, Mel, but I wanted to just clarify where we are and what our thinking is with respect to further evolving our donor eligibility criteria for men who have sex with men. And there are a few data points here. So earlier this year, a couple of months ago, we made a submission to Health Canada to alter our screening and collection process for source plasma donors. And to find a mechanism by which we could bring certain individuals men who have sex with men into our source plasma donations who previously would have been ineligible to donate. That submission is sitting with the regulator now. If approved, and I'm hopeful it will be, if approved, this will take effect in our London and Calgary source plasma donation centers first, and I'm hoping that that will be this fall sometime. Beyond the opportunity for men who have sex with men, gay, bisexual, and other men who have sex with men to potentially donate blood at Canadian Blood Services, we have done a lot of work. You mentioned this in your introductory remarks, Mel, and continue to further evolve the examination of the evidence and the standards of practice and the data available to us. The members of the public will know, of course, the board knows this well, that our sister organization in the UK changed their policy only on Monday of this week and went from a 3-month time-based MSM deferral policy, the same as we have, to a behavior-based policy asked of all donors. And it is Canadian Blood Services' intention to do likewise. So as we speak, quite literally, we are beginning to put our submission requirements together to understand what the evidentiary base needs to be, building on the research work done, building on the understandings that we have and the evidence that we believe will be required to support a submission. So we are doing that work as we speak now. And our intent, to be very clear, is to move from a time-based deferral policy, the 3-month deferral policy that's been in place for 2 years now, to a set of sexual behavior-based questions that will be asked of all donors, rather than a time-based deferral criterion for men who have sex with men. The work is underway now, and our hope is to make a submission to Health Canada by the end of this year. Plasma, I know I'm running out of time. I'll be very brief, Mr. Chair. You mentioned this in your opening remarks. One of the major thrusts of work, despite us having to navigate a pandemic, has been to evolve the work on source plasma collection so we can do a better job in Canada of manufacturing immunoglobulin from Canadian plasma. You can see that we opened Sudbury and Lethbridge this past year, and Kelowna opens in about 6 days' time. So 3 of our first centers are essentially up and running, achieving, if not exceeding, targets. Incredibly committed plasma donors in those communities, wonderful staff, new facilities, very proud of those facilities there, and tremendous work by the plasma team led by Jean-Paul Bedard and his excellent group in the organization. What are we doing to go beyond those 3 centers? again, you mentioned this in your remarks, Mr. Chair. I've shared with the board many times this past year the ongoing risks we face, not just in Canada, but globally, around access to immunoglobulin products based on the starting raw material of plasma. And these are risks that we've been paying tremendous attention to. And we have made it very clear that our objective is to collect significantly more plasma in Canada under our control so that it can be used for domestic IG immunoglobulin product, and hopefully in a vertically integrated domestic end-to-end supply chain from collections through fractionation to use for patients. As a result of all of those pressures, what we've done is two things. I mentioned this in the PPRP summary. We have purchased and acquired additional immunoglobulin to make sure we can meet patient needs in the sort of short to medium term. But in the longer term, it is about expanding our plasma network. And so in this fiscal year that we're in now, we will be opening new plasma centers in Ottawa, Brampton, and Winnipeg will sort of just be the start of the next fiscal year. So the planning for that one is underway. Those are 3 more to add on to Kelowna, Lethbridge, and Sudbury. And then our intent is to continue to open further centers in subsequent years. And this references the support we receive from our federal and provincial government partners. Lots of work on the well-being of our workforce. And I'm not doing this justice, just watching my clock here. But as you know, Mr. Chair and board members, we've continued to develop a lot of programs to ensure that the health and well-being of our workforce is given high priority. And by this, I mean both the physical as well as the psychological and mental health and well-being, because it is so important, not just at this time, but particularly given the stresses that all of us as humans are feeling as a consequence of the pandemic. So a lot of work this past year, many focuses on mental health, and we are trying to bring this really into the forefront of the work we do at Canadian Blood Services. Lots of programs to support our employees, lots of dialogue on making sure we talk effectively and openly around the importance of mental health. This is just some data to support that. As the board members know, we have an employee assistance program, and you can see that its use went up in the sort of middle months of the pandemic, Q3 and Q4. That is actually a good thing. We do not view that as a bad outcome. That means that individuals are making use of the tools that we have available in the organization. Again, I'm going to go through this quickly and not do sufficient justice, but it is a theme of the discussions later this afternoon. A lot of work this past year on diversity, equity, and inclusion. And as the board knows, and I've made it very clear many times to the board, we have a very firm and a very clear commitment to mature our capabilities and our maturity as an organization when it comes to all matters of diversity, of equity, and of inclusion. We are not where we need to be. I have been very clear in declaring that. We have declared that we have systemic racism in our organization. We have made clear commitments to address the gaps that we have. We are seeking to engage with communities, with partners, with thought experts in this space. And this is a journey that Canadian Blood Services will be on for a long time as we seek to do better and do differently and do more than we've done in the past few years. Some of the activities that the board is aware of, we've enrolled in the federal government's 50-30 challenge. We've established a number of employee resource groups that are essentially self-directed groups for individuals who identify in a variety of ways, whether LGBTQ+, or Black, Indigenous, or people of color, or women in leadership roles, or persons with disability. We are providing the safe space for these employees. We have lots of activities, lots of projects underway, which again, I will not do justice to in the interest of time, but they are shown on this slide here. And I know we will be talking a little bit more, well, a lot more about that later this afternoon. And just to close, Mr. Chair, because of course, one of the things we measure is, are we keeping the organization in a state of control, and are we achieving our organizational excellence objectives? So there's a lot of data behind this one. I'll just summarize. Canadians continue to have high trust in Canadian Blood Services to be there for them despite the pandemic. Our quality indicators, which are reported at great length to the SREC committee, continued to hit target this year, despite the many challenges and uncertainties of the pandemic. Our focus on productivity and efficiency continues, and you can see that across all the major indicators, recruitment, production, and testing, we have had very, very high performance on productivity and efficiency. The one area this year that was impacted was our collections productivity measure, and that's because of all the added steps we put in place on our collections environment from a physical distancing and a process point of view to protect the health and well-being of donors and employees. Our customers continue to trust us. And literally, Mr. Chair, in the last 30 seconds, I do always like to make sure I report on the financial outputs of the year. Of course, Pauline and her team give a much more detailed report to the Finance and Audit Committee, which happened at the end of last week. The take-home message on this slide: the working capital health of the organization is pretty much the same as last year, unchanged. But there's been a lot of moves within the components of working capital. And the major story on this slide is to report, if you look at the bottom in the middle, inventory levels much higher at the close of this fiscal year than a year ago, 230 million versus 157. And that's as a consequence of all that additional product we bought to mitigate risk in about ensuring patients had the products they needed. And that increased inventory has had a downward pressure on our unreserved cash that has gone down from about 120 to 48 million, which is still within our risk tolerance band. We had 37 days on hand. We're now down at about 14 days on hand, which is the lower end of our risk tolerance, but still within our risk tolerance. Receivables, prepaids, pretty much in line with the previous year. On a cost basis, this slide and the next are the last. You can see that we have increased costs substantially this year, all those red bars on the waterfall chart, as a result of pandemic costs. So whether it's employee-related costs such as pandemic leave, the purchase of PPE, personal protective equipment, enhanced cleaning, enhanced transport costs, and so on. We invested a lot of money to protect the organization. We were able to offset that with savings, less travel, less meetings, less money spent on donor food because of the way we changed our process, and less projects. We deferred some project spend, so we were able to essentially reduce some of those incremental costs. And as you can see, at the end of it all, our costs went up by about $6.5 million year over year. On the plasma protein products cost basis, a lot of puts and takes that I won't go through here. Some we spent less money on, some we spent more money on, some is driven by utilization, some is driven by pricing. But at the end of the day, on a year-over-year basis, the total cost of goods was flatlined, almost identical costs this year compared to the previous fiscal. And our insurance captive, Mr. Chair, remains in extremely strong financial health. We have more than enough assets to cover all the insurance requirements, all the statutory and market volatility reserve requirements, and both the assets of the insurance company and the premium net assets above all of its obligations remain in very positive market territory. And Mr. Chair, I recognize I'm over time, but I am also done.
Thank you, Graham. That covered a lot of territory, and we skipped over a lot of important items. I didn't skip over, but rushed through them. Dunbar had a question coming back to digital appointments.
Thank you, Mr. Chair. My question really is, it's great to see the progress. We know that there are a number of Canadians that don't have access to the internet or technology or the capability. As we keep improving like we are, is there still ways for those people who wish to donate blood to have easy access to our systems like call centers, etc.?
Absolutely, Dunbar, and that is an important observation. I mean, of course, the aspiration is to rely more and more on digital channels because they are much more efficient. And we actually find that we have what we call more sticky appointments if donors book through digital channels. But as you say, there are those folks who simply choose not to use apps and smartphones and what have you. So yes, they still have the means to book appointments through our call center. There's lots of ways that individuals can do that. We also are encouraging most individuals to fill out their questionnaire at home on a computer or on their smartphone, and they just bring the QPass when they come into the center and scan it onto our technology. That's our preference, but if somebody wishes to come in and do all of that when they walk into the center and do it on the tablet at the front of the center, we absolutely allow that. So we really do want to optimize the use of our digital channels, but we have to accommodate really the wishes of our donors and the different segments of society that make up our donors.
Thank you. I see no other questions from board members. And in light of the time, I thank you for your report that provides a lot of information and gives the public who are watching a great overview of the operations of CBS. Let us turn very quickly to the last item before we break, which is the approval of the financial statements, just so that people don't think we are simply rushing through this. On Friday of last week, the Finance and Audit Committee met, and yesterday, Judy Steele, the chair of that committee, reported to the board. But let me turn it over to Judy now to propose the approval of the financial statements.
Thank you, Mr. Chairman. The consolidated financial statements for the year ended March 31, 2021 were prepared by management and audited by the external audit firm KPMG. The Finance and Audit Committee formally met with KPMG twice. First, to review and approve the audit plan and associated audit fees, and second, to review the results of the audit. KPMG confirmed that the audit was conducted as planned. They have substantially completed the audit and will be issuing a clean audit opinion. Management presented the financial statements to the Finance and Audit Committee and noted the following. As Graham noted, inventory has increased from the prior year, mainly in IG because of, number one, the supply shortage concerns, and two, lower than anticipated product demand through the year. The increase in inventory has placed some pressure on cash position. However, this has partially been offset by healthy members receivable. By healthy, I mean not too high. Unreserved cash ended the year at 14 days, which is at the low end of our target, 14 to 45 days. Incremental COVID-19 costs of $18.3 million were managed through cost reductions and reprioritization. The Finance and Audit Committee is recommending that the board approve the audited consolidated financial statements for the year ended March 31, 2021 by passing the following motion. After review and discussion, on motion duly made, seconded, and unanimously carried, be it resolved that the board approves the Canadian Blood Services audited consolidated financial statements for the year ended March 31, 2021. I will move that, please, Mr. Chair.
Thank you. And do we have a seconder? We do, Brian. And does anyone disagree? Hearing none, I'll take that as passed and approved. Thank you very much. Every $1.4 billion counts. Thanks, everybody. I'm going to suggest that we take a 10-minute break and we reconvene at 2:30. I'm encouraging everybody to keep themselves connected, and we will, you can turn off your mic and your video if you like, but let's come back at 2:30. Thank you. Welcome back, everyone. We had a lot of material in the first hour and a half or 2 hours, but now we come to the public questions and answers, and hopefully answers. We'll respond to questions that have been submitted by members of the public. Les questions du public nous seront transmises en ligne. Everyone who submits a question will receive a response. However, if we can't do them all in this context of this online meeting, if we run out of time and can't get to your question during the live session, we will follow up and ensure you receive a written response within the next few days. So please do submit your questions. They're valuable to us to receive, and we will respond to them, and we'll deal with as many as we can orally during this meeting. Let me turn it over to Dina Jones, who's a member of our communications team, who will read the questions. Dina, we're ready for the first question. Over to you.
Thank you. Our first question comes from Davis Bain of London, Ontario. Dr. Scher, 18 months into this pandemic, what lasting impacts do you think COVID will have on the blood system?
Thank you, Davis, for that question. I would answer it this way, that I think there are short and medium-term impacts, and there are long-term impacts that COVID is going to have, and we're sort of getting more comfortable in understanding what those are now. I talked a little bit about the short and medium-term impacts, so making sure we can keep our employees and our donors safe. I think we're going to be doing that for a while to come. I don't think physical distancing and personal protective equipment is going to go away anytime very soon, even after more people get vaccinated. Balancing that volatility of supply and demand, one of my board members asked me a question, how are we going to catch up for elective surgery and what have you. I think we're going to live with a volatile supply and demand situation for some time to come, and we are building in and need to remain agile as an organization to meet that. It's the longer term impacts on the pandemic that I think are really interesting. So firstly, we need to recognize that we're funded by provincial and territorial governments, by their ministries of health. And governments have spent massive amounts of money to protect the society and to protect us through the pandemic. So I think we recognize, as pretty much all publicly funded organizations do, that we're going to be in a period of very significant fiscal restraint, likely for many, many years to come. And so the question for us is, how do we continue to evolve the blood system, recognizing that we're funded by the public purse? And I think that's going to pose a challenge, not just for CBS, but for all organizations that are publicly funded. And we will work very closely with our partners on that. For me, I touched very quickly on some of the futures that we think we have to capitalize on that are going to be as a consequence of the pandemic. The obvious one that a lot of people talk about is, what is my work environment going to look like in the future? Am I going to work remotely? Am I going to work in the office? Is there going to be more technology available to me? So the whole redesign, not just of where I work, but how I do my work is going to change. And so we have this big body of work looking at the work of the future. And I think it will be different, both for the people who come and work at Canadian Blood Services and how we service the public. We need to look at that. We will have a heavier reliance on the digital world of the future and on automation throughout our process environment. So where we can look at putting in technology to automate our work so that we don't face some of the potential disruptions that we saw in a pandemic, such as large numbers of people potentially getting ill and workplaces potentially being impacted. So what's the right acquisition of technology to modernize our work environment? And I would say one other, I'll leave it at one other just so we can get to other questions. One other space, Davis, where we know that the pandemic is causing changes is in the relationship we have with donors. And I say that because human behavior has probably been irrevocably changed as a result of the pandemic. All of our lives have gone through changes, some of which we don't fully understand going forward. So what is the nature of the experience we have to provide to donors so that they keep coming into our facilities? What is the relationship we want to keep with them on a go-forward basis? There's a lot of work we are doing with blood organizations around the world, which we sort of called reimagining the donor experience. So how do we create an exceptional experience going forward in a post-pandemic world? Those are some. It's a wonderful question to kick off with because there's probably others, but those are some that come to the top of my mind.
Dina?
Thank you. So our next question comes from Travis Brooks of Sudbury, Ontario. There was a lot of talk about plasma donors helping COVID patients. What happened to that program?
Your question is aimed at the plasma that we collected from people who had recovered from COVID-19, and that plasma was used to support the clinical trials. I don't know if you saw my presentation a half hour ago, but I did briefly mention it. I'll recap. So Canadian Blood Services was asked by our clinical research colleagues across the country to support a series of clinical trials that were developed early on in the pandemic. And we would be the collector of plasma from patients who had recovered from COVID-19. That was our participation in the clinical trial. We would collect the plasma, do the necessary testing to make sure it had the right level of antibodies, and then we would provide that plasma to the clinical trial sites where the trials were being undertaken. So we did that, and we participated actively in these clinical trials. And as I reported earlier, both the Canadian trials as well as trials in other countries such as the UK, Netherlands, the US, pretty much all those trials showed after some time, after they had run through a number of patients, that the therapy, the convalescent plasma, was not having the desired positive clinical benefit that people thought it might have for those patients who were in the clinical trial. And so the trials were ended. And so we stopped collecting convalescent plasma. We remain very close to this, and we continue to keep a connection with the clinical community, because if they stand up additional clinical trials for other subsets of patients, we are ready and able to support those clinical trial sites with the collection of convalescent plasma again.
Could I just add, Graham, and you made this point in your presentation, but at the last open board meeting, we had a presentation by a patient who was actually a donor of plasma for the purpose. He was the first donor of convalescent plasma for the purpose of testing. And you made the point that just because we didn't show that it would work, or that we showed that it would not work, that was actually very valuable. And I want to just valorize the contributions of people that people made, giving plasma for testing to see if this was a viable therapy, and it turned out not to be.
Yeah, valorize is a good word, Mel, because I think these donors were incredible supporters of the clinical trial, for sure.
Thank you. So our next question comes from Erica Griffin of Antigonish, Nova Scotia. Is there any plan or research underway about malaria specifically that might allow people who have had malaria to eventually become blood donors?
So Erica, I'm going to actually, malaria has been a real challenge for blood service providers around the world, because unlike a lot of the other testing that we do, for example, hepatitis C, hepatitis B, HIV, West Nile virus, testing for bacteria, there isn't a readily available test for malaria to screen out donors when they come into our facilities to do a blood test and see if they have presence of malaria, and therefore we would defer those donors. So we've all had to adapt to safety protocols in the absence of an easily usable test on every donation. And so what many blood services, ourselves included, have done is had a series of questions that you ask donors that would signal the potential that they've been exposed to malaria. So either they traveled to certain geographic sites where malaria is endemic, or they might have lived there in places where malaria is endemic. And so we've relied on a series of really travel and residency-based questions to try to screen out people from malaria endemic areas. The problem with that approach is it's been a very broad net cast. And so I might answer, yes, I was in Mexico at a certain point in time, and therefore I might be deferred, but I might have been there for such a short period of time or in a region of the country that wasn't necessarily endemic for malaria. So we constantly revise and update the questions that are asked to make sure that the regions of endemicity that we ask about are the relevant ones, and we follow guidances put out by a number of leading organizations around the world, including the Centers for Disease Control. So we revise the list of endemic regions. We have also eliminated some of the blanket deferrals that we used to have, particularly if your exposure is for a very short period of time. So somebody might have just gotten off a cruise ship for a few hours, and then under our previous capture questions, they would have been deferred. They are no longer. Our questions are more specific. And this is an area of research that we continue to monitor very carefully. As I say, the ideal situation would be a suitable test is identified that is sensitive and specific enough for malaria in blood donors. And unfortunately, such a test just doesn't exist yet, because that would simplify some of the complex approaches to malaria protection that we rely on now. Back to you.
Thank you. Our next question comes from Elaine Foster. We saw the UK move to a new model of gender-neutral screenings this week. Is Canadian Blood Services going to follow that approach? And if so, when?
I'll just start, Graham, by saying that I mentioned that in my opening remarks, and as we've noted, and Graham noted this in his presentation, we have already applied to Health Canada for approval to move to a behavioral questionnaire rather than a sexual practice or orientation question. And we will plan to do that for more. But Graham, you addressed that in your presentation, but this is worth elaborating.
Yeah, again, thank you for the question, Elaine. So I don't know if you heard my presentation, but I do want to repeat it because it's such an important one. So to be clear, we made a submission to Health Canada about a month or 6 weeks ago to alter the way we identify potential donors for source plasma. So these are donors who would come into our plasma collection sites, and we're piloting this work initially through our London and Calgary sites. There would still be a question around men who have sex with men, but if they identify to a certain set of answers, those donors would be eligible to donate. That submission is sitting in front of our regulator right now. We are obviously going to work with our regulator to make sure that the submission meets their needs, and we're hoping we get a positive response to that. And if we do, we would implement that change initially in our Calgary and London sites, probably by the fall of this year, obviously pending the outcome from the review by the regulator. What I announced today was further clarity on a broader approach for all of our blood components. So for blood donors, not just source plasma donors, whether they're platelet donors or whole blood donors, we have stated for a very long time that our intent is to move away from a time-based deferral policy of men, gay, bisexual, or other men who have sex with men, to a sexual behavior-based policy that would be asked of all donors, which is what you described, the approach that the UK adopted earlier this week, actually. So the organization in the UK, National Health Service Blood and Transplant, they implemented that policy change on the 14th of June. And yes, our intent is to do very much like they're doing in the UK. We are putting together the work necessary right now. And what I announced earlier today was that it is our intent to make a submission to our regulator before the end of this year to try to effect the same sort of approach that our colleague organization in the UK has now put into place. We've been very clear for the longest time that that is our strategic intent. We are building the necessary evidence and science to support that. A lot of the research studies that we have funded for the last few years have been central to that. And we're doing a lot of the analysis right now, but are reasonably confident that we can have a submission later this year. And then, of course, it still needs to be approved before we can implement the change. So I can't speak to an implementation timeline just yet, but certainly this is something we will keep our board, obviously, members in the organization, but the public very much apprised of. Next question.
Thank you. Our next question is from Jessie Hennessy of Mississauga, Ontario. I'm a nurse at a busy hospital. Whenever I can, I encourage people to donate blood. Lately, I've heard people talk about not being allowed to make a donation if they've had a COVID vaccine. Is there any truth to that?
JC, one of my board members asked that very same question of me during my presentation. There's a short and probably a much longer medical answer to that. The short answer is no, it is perfectly acceptable for individuals who've been recently COVID-19 vaccinated to be a blood donor. Now, of course, if they have a side effect to the vaccine, if they have a fever or they're feeling really unwell, they wouldn't pass the screening criterion, so they wouldn't be accepted to donate on that day. But if they are otherwise feeling well, if they have no symptoms, then absolutely somebody who's been recently vaccinated can come in and donate. And the reason, the sort of scientific evidence behind that is the nature of the COVID-19 vaccines, whether it's the mRNA vaccines, the Pfizer Moderna, or the viral vector vaccines, such as the AstraZeneca one. These are all what are called they're non-live vaccines. So there are a certain class of vaccines where there is some live virus in the vaccine. And those vaccines, there is a significant deferral period after somebody's had one of those vaccines before they can donate. But none of the COVID-19 vaccines fit into that category. And so both the regulators, the manufacturers, and ourselves, we've all looked at the science and the data here, and our medical team has done an extensive amount of analysis on this, and we're absolutely confident that it's both safe for donors to donate after a vaccine, and the corollary is equally important. It's very safe for somebody to receive a unit of blood from somebody who's had a recent COVID-19 vaccine. You can't transmit the vaccine through the donated blood. It doesn't work like that. And so it's perfectly safe for the recipient to receive a unit of blood from anyone who's been recently vaccinated as well. Back to you.
Thank you. Our next question is from Bob Simcoe of Orillia, Ontario. Recently, I saw one of your branded trucks at a hospital, which I assume was delivering bags of blood for patients. This got me thinking. You must have hundreds, if not thousands, of delivery trucks driving around the country every day. What is the carbon footprint of those? Are you looking into replacing these with electric vehicles in the future? And are there other things that you're doing to go green within your operations?
Thank you very much, Bob, for that. So I don't have all the numbers at my fingertips, but I don't know how many trucks we have in our fleet. It's a lot. What I do know is that our fleet drives cumulatively many millions of kilometers a year. So given the size of the country and that we're delivering product to hospitals in every part of the country, and we collect blood in many, many geographies spread around the country and need to get that collected blood into our manufacturing sites and so on, we drive many millions of kilometers each year on our fleet. I want to say it's north of 6 million kilometers, but don't hold me to the number. It's a lot. But yes, we do have a large fleet, and the carbon footprint of our fleet is something we have been paying attention to. We estimate that the fleet represents just north of 10%, maybe as much as 15% of our total carbon footprint as an organization across all of our facilities and other sort of contributors to our carbon footprint. So our fleet is a significant contributor. It's certainly not the only one. And I know that our logistics group and our finance and corporate services groups, they're looking at a number of opportunities to modernize our fleet, which we're changing all the time. You know, we have to evergreen our trucks, but we want to make sure we're looking at options of either or fuel efficient vehicles, hybrid vehicles, or fully electric vehicles. And there's an analysis underway right now that will come to management sometime, hopefully not too far down the road, to look at what it would cost us to essentially begin to turn over more and more of our fleet to either hybrid or electric, or certainly more fuel efficient vehicles. The second part of your question I do want to answer, and that's one I know a little bit of data about. So what else are we doing in our operations to contribute to being, you know, good corporate social responsibility? We built a new facility in Calgary, Alberta. It's our newest and biggest facility it's our newest in the whole country and the biggest in Western Canada. It's a very large facility where we manufacture our blood products. We test our blood products for all of Western Canada. We store a very large proportion of our inventory for Western Canada. So it's a hugely central part of our facility. Mel Kapp, our board chair, and I have visited it a few times. Glenda Yates, our vice chair, and I were there before the pandemic. Some of them have seen this facility. We put a large array of solar panels on the roof of that facility when we built it. It was our conscious decision to, as I say, to really be a good corporate, socially responsible citizen. Our understanding, at least at the time we built this, and I think it's possibly still true, it was the largest solar array in Alberta when we built that facility, and it contributes anywhere between 20 and 30% of the total facility's energy needs on a given day, depending obviously on the season and the temperature and what have you. So that's an example of what we're doing across the organization. That's a pretty big one and an impressive one. But we have a corporate social responsibility agenda, and we are seeking to obviously do more and more to advance our work, carbon footprint being one important metric. Thanks for that.
I would just add, when I visited and got the tour by the construction manager, he pointed out that it was LEED Gold certified, and that so I asked the question, why was it not LEED Platinum? And his answer was because there was no public transit to get to the facility. But if it had, and if the city brings a bus, then we would get LEED Platinum certification.
Thank you.
Thank you. So our next question comes from Gavin Boyd of Leamington, Ontario. Gavin says, thanks for this opportunity, Dr. Scher. Is there any concern about the potential for one of these coronavirus variants to become transmissible through blood?
Gavin, so I am no virologist. I am a hematologist by training, but one of the things we have at Canadian Blood Services is deep subject matter expertise in public health, in infectious disease and medical microbiology, surveillance and epidemiology, many physicians and scientists on our staff, hematologists and pathologists, all of whom are constantly assessing what the risks are to transmission of agents through blood products. The one thing we know, and we've had many, many presentations to management and on this topic, is that respiratory viruses like the coronavirus are not blood-borne viruses. So they are spread through other means of transmission, droplet and aerosol and what have you. But no, there is no concern that the SARS-CoV-2 virus, the virus that causes COVID-19, is transmissible through blood and blood products. So we're assured of that, and we've therefore been very clear in assuring recipients of our blood products that there is no risk of acquiring COVID-19 through a blood transfusion or a blood product. That said, and you may have seen this in my presentation, we pay attention to many, many other pathogens, both known ones and emerging pathogens, and to seek to understand what the likelihood is that any of them may or may not be spread through either a blood transfusion or an organ or stem cell transplant. And so that's that's work we do on a constant basis. We're constantly surveying and collaborating with subject matter experts around the world. It's why the technology that I know I rushed through pretty quickly in my last slide deck on pathogen inactivation technology is so important, because we see this as a bit of a game-changing paradigm, because it will, once that technology is fully deployed, and we're a few years away from that, but once it is, it actually not only do you not have to worry about testing for a new pathogen, because you can rely on the fact that this technology will inactivate that pathogen. So it becomes another layer of safety. But in terms of the question specifically around the SARS-CoV-2 virus, no, it is not transmissible by blood, and recipients need not be concerned that that's a means of acquisition of COVID-19 disease. Back to you.
Thank you. Our next question comes from Barb Killeen of Calgary, Alberta. I just saw an online ad for Canadian Blood Services and didn't recognize the logo. What happened to the red blood drop and the "It's in you to give" slogan? I always liked that.
Well, thank you, Bob, for that. So the tagline, "It's in you to give," we had that tagline for many years. It served Canadian Blood Services extremely well. And you are not alone, Bob. There are many people who still recite that tagline to us. So we know that it worked, and we know that it resonated. And we did have the blood drop as our initial logo. A few years ago, we undertook a very extensive review of the whole organization's brand. And by brand, I mean a brand system. I don't just mean a logo. We tried to understand what our value proposition to the Canadian public and those whom we serve was, and was our brand system adequately representing them? And a few key findings. So one is, because we had evolved from really principally a blood organization to a focus on blood and plasma and stem cells and organs and tissues, we wanted to make sure that our brand system really represented all of the products and patient groups whom we are here to serve, and it wasn't exclusively blood focused. And the blood drop really in and of itself wasn't serving that purpose. The "It's in you to give" tagline, while very positive and much beloved by many, really had a focus on the donor exclusively. And we wanted to also make sure that our brand system reflected that connection between donor and recipient, between patient and clinician, so that sort of integrated system that we are part of. And so we went through extensive focus group testing and lots of research with brand experts, and we really refreshed our brand system. And the sort of key things you see in our new brand system is, it's about being Canada's lifeline. So we wanted to communicate the fact that what we do here is act as a lifeline, linking donors to recipients, researchers to clinicians, and so on. So this notion of a lifeline was very important. And we looked at many logos, and the one we landed up on was the infinity sign that you see displayed, and I'm wearing on my tag here. And if you actually pay attention to it, the blood drop didn't disappear. So the red part of the infinity, if you turn it 90 degrees, is in fact our blood drop, and we wanted to retain that. But we also wanted to bring in the color system that represents the transplant universe that we support. And organ and stem cell transplants typically use a shade of green. So we brought that into our brand representation as well. I could go on, but I won't. So that's the major evolution of our brand system. It's not that we didn't like "It's in you to give" anymore. We liked it, and we still do. But our brand was refreshed to really do a better job of reflecting all those we serve. Any more questions?
Yes, we actually have a couple of questions left. We have about 6 minutes remaining, so hopefully we can get through them. So the next question comes from Dr. Peter Jaworski, and Dr. Jaworski has actually submitted a couple of questions. So I will give it to you sort of in two parts. I'll give you a follow-up once you've answered the first part. So the first part is, how is our supply of immunoglobulin? Are we anticipating any supply issues as a result of the reduction in plasma donations in the United States?
Hi, Dr. Jaworski. Thanks for that question. Yeah, so The supply of immunoglobulin, you may not have seen my presentation earlier, it is extremely challenging, and it was before the pandemic, and it certainly was greatly amplified by the pandemic. And two things really happened. So there was a dramatic reduction in the amount of plasma collected by the large commercial plasma industry in the United States. And there were significant manufacturing challenges in some of their facilities around the world where they actually do the fractionation. So we saw a pre-existing sort of pressure on our immunoglobulin supply made very much worse by the pandemic. And that has persisted to this day. There was a very significant IG shortage initially, and it continues now even 15 months into the pandemic. What CBS did preemptively when that was emerging was, we sought to identify opportunities to acquire more immunoglobulin product than that which had been contracted to us through our existing commercial contracts. And because of the leverage power of our national bulk tendering and purchasing, we were able to do that, and we worked with several of the providers internationally, and we acquired additional product so that we could continue to meet IG supply needs for Canadian patients on an uninterrupted basis, which is what we were able to do. I don't know what the follow-up part of the question is.
Sure. So the follow-up is, have the prices for immunoglobulin remained the same, or has there been increases in how much Canadian Blood Services pays for immunoglobulin?
So there are a couple of ways I'll answer that, Dr. Jaworski. So firstly, we enter into long-term multi-year contracts to buy these products, as you may know, and the pricing is generally set through those contracts. The global price of immunoglobulin has gone up substantially as a result of the plasma shortages that your question was sort of premised on. So yes, we have seen the global prices of IG go up and go up substantially, and that is that happens in this industry like many others. When product is in short supply, the pricing goes up. We are protected by our long-term contractual commitments in the product that we buy. When we buy additional product, outside of contracted amounts, we have to really buy at what may be the global spot market price there. And so, yes, the price went up very substantially as a result of the pandemic. But this, I'm going to use your question just to underscore one other important point. As you know, we're on a path to open up and operate many plasma centers in Canada under our auspices, and we have not seen the price of the plasma that we're collecting going up. So that's really important, because we then use that plasma to have it contract manufactured into immunoglobulin for us and for use by Canadian patients. So in fact, it is demonstrating the significant benefit of a domestic capability of collecting plasma to help ensure greater security of supply for Canadian patients. Back to you.
Thank you. And this is our final question, and it comes from Salah Nur of Toronto, Ontario. It was mentioned that Canadian Blood Services supported the COVID Immunity Task Force, that you collected a little more blood during the donations so that a sample could be used for testing. Did you have to take written consent from donors for this?
Thank you very much for that question. And, I perhaps should have addressed it when I spoke to the work we did with the Immunity Task Force. So when we were approached by the Canadian COVID-19 Immunity Task Force to see if we could collect samples from blood donors and that material could be used to measure antibody levels in blood donors, this whole question of consent was central to the work that we were going to do. So we did an extensive analysis, our ethicists were involved, and before we could say yes to the ability to participate in that program, we needed to resolve the consent issue. So I want to clarify one important part of your question. We did not collect any additional blood samples from donors. When a donor makes a donation, a blood donation or a plasma donation, we obviously collect the unit of blood from that individual, and then we collect a series of small tubes, and we use that blood to do all the routine testing. That is part of the consent that donors give when they routinely give us consent for donation. And so when we are finished all the testing that we do, there is typically a small amount amount of plasma or serum left over from the samples once we have concluded all of our testing. We normally hold on to that, and after a couple of weeks, if it's not needed for any other testing, it's discarded. So we were able to make an assessment that we could use that additional plasma without having to collect anything more from a donor. But what we landed up doing, and this was on the advice of our ethicists, is the material that we tested for COVID-19 is not linked to a donor. There is no, we take the samples from our routine testing laboratories, and where we've done the COVID-19 testing, it's all anonymized. There's no link back to a donor. And so we're not actually doing specific donor testing. We're essentially testing anonymized samples. And because we have a capture consent question around your material may be used for research purposes, it was within those standards. But it is not nominal testing, so we can't go back to somebody and say, your sample tested positive for COVID-19 or not. And as such, we didn't need additional specific COVID-19 consent. But I'm really glad that question got asked, because that was an important consideration before we could even embark on this work.
Thank
Judy,
you. I think we're, Dina, we're done. Yes. For now, we have. I'm going to just note, as I said at the outset, that if there are any other questions, please do submit them, and we will get back to you with answers. I want to thank Graham for your candor and openness in response, and thank you, Dina, for posing the questions. We have 7 presentations to come, 5 minutes each, with responses that will take longer, and we will come back at 3:20 to hear those presentations. So let's take a break now, and we'll come back at 3:20. Thanks very much. Welcome back, everyone. I want to just point out, Lorraine Musqua had raised the idea that the CEO's presentation should be available on our website, and it will be, and it'll be posted within the next day or so if people want to go back to it for reference or to share with your friends, whatever. But we're now at the portion of the open board meeting where we hear from members of the public and key stakeholder groups. This is a very important aspect of the meeting for the board, and all of the board members take this part very seriously. It gives us an opportunity to hear from and engage with the people that this organization was created to serve. Today, we'll hear from 7 presenters on a variety of topics. And let me thank all the speakers in advance for taking the time to be with us today. We put you in the order that you came in, actually. Your contribution enriches our focus on achieving the best possible outcomes for Canadian patients. Just a reminder to speakers, you'll have 5 minutes to make your presentations. There'll be a timer visible on the screen to help you keep track. Given the virtual nature of the meeting, we'll need to be quite diligent about adhering to the set times. You'll notice that Dr. Scher didn't have any trouble going over his time, but we'll try to keep our answers focused and to the point as well. With that, let me invite our first speaker, Angela Diano, the Executive Director of Alpha One Canada, to make her presentation. And Angela, I understand, could not be with us, but has a video.
Thank you, Mr. Chair and Dr. Scher, for permitting Alpha One Canada to continue to raise awareness during the open board meetings about the inequities to a plasma replacement therapy for severely affected Alpha One patients. I do appreciate the board's patience during the last 4 years, as I have used this platform to communicate the desperate need of Alpha One patients. Though incredibly grateful that after many years of asking, the PTs have finally permitted a CADTH PPP review for augmentation therapy, I would be remiss if I did not communicate that the continued wait results in irreversible lung deterioration for Alpha One patients. Alpha One patients experience premature death if they do not commence the only specific treatment for this disease as soon as they are diagnosed. There is a tragic unmet need here that the provincial and territorial governments can rectify if they would allow for interim coverage during the review process, or if they would permit an expedited review because lung destruction is irreversible. Physicians across the country do not have an alternative to treat Alpha One patients. Mr. Kelly McKenzie of Edmonton, Alberta, is a 34-year-old Alpha One patient with less than 50% lung function. Dr. Warren Ramesh prescribed Kelly treatment, but there's no access for this young man. Now he is in for the fight of his life because his disease is progressing rapidly, and he has no access to augmentation therapy. He actually thought of giving up multiple times, but told us that he could not do that to his parents and family. I hope everyone will really listen to Kelly's story today and understand that severely affected Alpha-1 patients do not have time to wait. The unmet need here is real, and it is dire.
I had all these plans to buy a house and have a family and stuff, but we're in Edmonton and I have Alpha-1 antitrypsin deficiency. Before I knew that I had anything, I'd be snowboarding or even just at work, and I'd have to stop and rest all the time. I'm 34 years old. People would think I'm lazy, and I would just think I'm super out of shape, but it just never got any better. I didn't think anything was really wrong with me. I just thought I was out of shape and it would get better. I didn't want to go just because I knew I'd miss a bunch of time at work, and got my blood test, and they found out then that I had Alpha-1 antitrypsin deficiency. Well, they say my liver doesn't produce enough of this enzyme called Alpha-1 antitrypsin. It's needed for lung protection. People always tell me that the lungs are one of those things that kind of repair themselves if you give them a chance, but not mine. I definitely go for much shorter longboard rides. They're not as fun anymore. I just get right out of breath, and it's hard to enjoy it when you're gasping for air. I was actually pretty surprised that I'm not covered when it's a medication that will help me live a quality life, and without it I'd just deteriorate. I thought my union hall would cover me. That's all I've known. That's all I know is I joined the union when I was 18. I've never worked any other job other than pipe fitting since 18. I'm at this point where I don't know if I can pipe fit anymore. I went roofing after I got laid off. I went roofing for a day. I realized in 20 minutes that I can't do that anymore, because that's what I used to do if I wasn't pipe fitting. People shouldn't have to move to Quebec or BC to get coverage. You should be able to stay where you are, get coverage, and continue paying taxes and being a citizen of the province you grew up in. I don't know, I'm Alberta born and raised. I work in Fort McMurray, but now I got to leave my province. I think anybody would uproot their life wherever they are and move to where they can get coverage. You need coverage. I need it to live. As much as I don't really want to leave my life, I kind of have to. I feel like I'm still young. I've got a lot of years left in my life. I should. I've got a lot left to give, a lot left to contribute. Government should pay for this. They should. I don't know how they could just let me waste away without treatment. I want to continue working. I want to buy a house. I want to live my life, And they just say no. I worked so hard my whole freaking life to get where I'm at and to go where I thought I was going, and I feel like they should let me live.
I want to say thank you, Angela. I'm not sure that thanks are the point. That's a wrenching story. I guess this is a glass half full kind of story in the sense that we've made some progress with CADTH, but there's still a long way to go. Graham, do you want to address some of that? Can't hear
Angela,
you. Yeah.
Can I get my mic on, please?
Yep, you're on.
Thanks, Angela, for being willing to share the ongoing narrative. Sorry you can't do it in person with us. And thank you, of course, for sharing Kelly's story. So I just want to sort of update a couple of important points for the board and for members of the public. So Angela has been a presence at this public board for some time now, as she said, and she's been quite persistent in trying to get a decision made to review this product. So as she acknowledged, the provincial and territorial governments agreed in January of this year to allow the review process of Ziihmera, that's the name of the drug in this category, to go through the CADTH CBS review process that I spoke to earlier in the board meeting. The important next step to happen, I just want to be clear with the board, is that the manufacturer has to make the submission to CADTH to get the review underway. And to my knowledge, at least at the time I was preparing for the board meeting, that submission hadn't been made by the manufacturer. It may be being made imminently, but they need to initiate the review process. And as soon as they do, the product then gets into the review process. And then once it's gone through the review, at the end of the day, a decision will be rendered ultimately by the PT, Deputy Ministers of Health, whether the product will be on our formulary or not. We have certainly stated our support for that in the past, but at the end of the day, it's up to the provinces to decide. And I just want to make one other additional point, because Kelly's story, as you say, Mel, is pretty compelling. There is an opportunity for patients and manufacturers of the drug, in this case, the manufacturer of Ziihmera, that there can be compassionate access opportunities. Now, I'm not saying that the manufacturer and Kelly would sort of meet those terms, but until a product is on formulary, manufacturers do have the capacity to provide product on a compassionate program basis. Canadian Blood Services has no ability to access product unless it's on our formulary, which is really what I know has been Angela's request for all these years, is that the product get reviewed and hopefully get a positive review and be on our formulary. But until such time as it is, we do not have the ability to access the product.
Right, Angela, I mean this in the most positive way. I hope we don't have to continue to have this conversation, but in the meantime, thank you for reminding us and bringing such a compelling story as Kelly's. Our next presenter is Kat Lantane, the Executive Director and co-founder of bloodwatch.org. Kat?
Mute. Can you hear me now?
Yes.
Okay, great. I can't see my time. Oh, there it is. Is it started?
Just go.
Okay, I'm gonna go. The first thing that I wanted to say to CBS is a massive thank you for everything that you've done during the pandemic. You had an extraordinary task on your hand and you stepped up for patients and for donors in the country, and we're incredibly grateful for that. We would also like to request again that we have a seat on the Safety and Supply Committee. We think that's a very important seat to have, and one that certainly our veteran advocates have earned. They used to be on it, but unfortunately, the gentlemen that used to be on that committee, of course, are no longer alive. So we can provide a representative from Bloodwatch to take that seat. And then I want to tell you about this amazing organization that was born out of Guelph and Waterloo. It's a youth organization called Project Life Bank. They were given an assignment to fix a problem. And they decided that the problem was reaching out to youth about blood and plasma donation. They picked Bloodwatch as their Thank a Advocate campaign. I think they already have 1,500 members. And I was talking to Chris talking to CBS about working with Project Life Bank and expanding their youth model across the country, because they are in fact our next generation of blood donors. And they're doing some really exciting and interesting work on social media. I have a big list, so we'll follow up with other things in a letter. But one of the biggest things we wanted to address is the repeal of the Voluntary Blood Donation Act in Alberta and the political silliness that happened in that province to repeal the act, particularly using unfactual content to remove a safeguard that's critical to protect the security of plasma supply in Canada. We really appreciated Graham's presentation there. It was incredibly strong, probably the strongest it's ever been. But what's extremely troubling is that because some parties or particular governments are so politically inclined of a particular point of view, they ignore the experts. And in our view, what that has highlighted is the important and urgent need for a federal protection on blood and plasma in this country. And we are really looking to you, to Graham, and especially to you, Mel, and to Glenda, who have the experience that you do as deputy ministers in the federal government, policy-wise, to engage the minister and our prime minister and the PMO's office to let them know that this is actually work that needs to be accomplished, because we can't permit these policies to come and go at the whims of market-driven corporate blood brokers over the safety and security of our national blood supply. It is wholly unacceptable and untenable. And so this is something that we aren't prepared to let go of. We will be working very diligently to have that provincial law reinstated and other provinces to come forward again with their own law. But it's a real problem, because I think that the public doesn't really have the appetite for the kind of political mumbo jumbo that happens when politicians ignore facts. And this law was repealed on the premise that it was going to secure the supply chain for people in Alberta. False. And secondly, the hysterical accusations that bloodwatch.org and organizations that were supporting a voluntary blood system were working with the government of Venezuela to try to make a coup to harvest people's organs across Canada. It's just gotten absolutely silly. And so we are looking for senior policy people to really take a step in at the highest level and make some commotion federally to shake that office so they understand what's at stake. And in closing, I just have a couple of questions regarding the Ontario pledge of $267 million to the plasma program, and your thoughts on the $20 million that Minister Freeland pledged to the plasma system for infrastructure to build an additional 8 facilities.
Thanks for that, Kat. Let me start with a couple of comments, and I'll let Graham address certainly the last few and Alberta. First of all, I appreciate your thanks offered to CBS, and one of the things I want to do is take that and give it back to the employees. You know, the frontline staff are the ones who really deserve the credit for having stepped up, and we're all very grateful for that. In terms of Project LifeBank and the like, we are in the process of reviewing how we engage with stakeholders, and we'll be back to you with in due course with some revised processes that we hope to institute, not directly related to Project LifeBank, but that fits into how we want to revise our piece. On the federal protection point, I'll just say that at this point, the board has unequivocally endorsed a voluntary, non-remunerative collection process for plasma and for blood. And I just restate what has been our policy and continues to be. Graham?
Thanks, Mel. Hi, Kat. Good to see you again. I'm sort of going to go in reverse order just to try and pick up on a couple of things briefly. So just clarity or questions around the $20 million federal announcement and the $267 million provincial one, Ontario one. So correct, in the federal government that Minister Freeland released a few weeks ago, there was an announcement of $20 million to support the opening of 8 additional plasma centers under Canadian Blood Services auspices. I reported on that earlier in my CEO report. So the first 3 of those will be opening essentially this fiscal year early into next, Ottawa, Brampton, and Winnipeg. So that builds on the Sudbury, Lethbridge, and Kelowna ones that are already open. And then our intent is to open 5 more in subsequent years, sort of year 2 and year 3. So it was a tranche of funding for 3 years. Essentially, if you want startup or seed funding from the federal governments to open these centers, and then they will be operated within our ongoing provincial financial support. So that's what the $20 million announcement from the federal government was, and we're very grateful for that. The Ontario announcement came out as part of their budget, and it was a bit of an unusual announcement. We actually needed to go back and clarify ourselves what it was. Essentially, what Ontario announced in that $267 million was their share of our ongoing operating costs for the purchase of plasma products and their share of the 3 sites that we opened in Sudbury, Lethbridge, and Kelowna. So it's no new dollars. I just want to be very clear. The Ontario government did not make any new announceable around new dollars to support plasma expansion. The Ontario government's made subsequent announcements in the pandemic about building biotech infrastructure in the province, and we applaud them for that because we do think there needs to be more biotechnology capability in this country, and Ontario should be central to that. So I wanted to just clarify those numbers. Thanks for the information on Project Life Bank. I don't know about it, but I heard you say, Chris, you've shared stuff with Chris, so we'll certainly follow up on that one. And then I lastly just want to make a quick comment on this notion of federal leadership on the policy front. So I think you may be aware, we've spoken about this before. So Canadian Blood Services is working with the federal government, with Health Canada and the provinces and territories to essentially, participate in a policy roundtable discussion. And the federal government is taking a lead on this to understand what the role of the commercial sector in this country ought to be. So I actually do think the federal government is engaged and involved in this. What will come out of that and what any policy instruments may be, that's really up to the governments to decide. But I just want and the board knows this, I talk to my board regularly about this, but for members of the public to be aware that with the support of the federal government and the provinces and territories, we are all seeking to have this conversation and understand what the policy requirements in this country need to be to ensure no negative impact on our ability to collect plasma and to operate the blood system.
Thanks, Graham. And go ahead, Kat. Yes.
I just wanted to say that's great, but our argument would be that policy roundtables and those discussions can't be fruitful without stakeholders as a participant. And that's one of the biggest problems that happen, is they happen in the vacuum behind closed doors. So I would like to say that stakeholders are invited and that they are participative around the table in a formal fashion.
We hear you. And as I said, we are revising our stakeholder engagement framework, and we'll be back to you with that. And just to say, on the other issues that you want to raise, please do send a letter, and as you know, we'll respond. Our next presenter is Jackie Badu, who's the president of HAE Canada. And although I don't think I've met Jackie before, well, we've certainly seen HAE before. Jackie?
Hi, my name is Jackie Badu. I'm the president of HAE Canada, and I feel very honored to be able to speak at this open board meeting today. I would like to thank Mel Cape and the rest of the board of directors. I am just in awe and so grateful that we have HAEGARDA listed in the CBS formulary. The preliminary data from our next national report card is showing good results, and this is very exciting to see. I would also like to thank everyone who organized the HAE Forum, because I felt this was instrumental to getting this through after. I would also like to take the time right now to thank Dr. Sylvain Grenier for his help in all of this, with Steph Kelly with the organization, and Daphne Dumbrell, who always keep us collaborative and positive, and just thank you very much. Also, I would like to thank Dr. Grenier for his time and keeping his promise that although we didn't get lanadelumab in the CBS formulary, hopefully, hopefully we've learned from this, but that he helped me put it through in every province. I wouldn't have gotten it through. Soon, hopefully we'll be able to say it's here, coast to coast. Thank you. I would also like to thank all the HAE treaters, and I mean all the treaters over the last decade. I'm starting with the first slide because these are the pioneers of it all. In the right-hand corner is Dr. Bowen, who's an honorary member of HAE Canada. His time spent, I remember the first meeting, he was there, Dr. Hebert, Dr. Yang, Dr. Karen Binkley, Dr. Stark, Dr. Warrington, Ritchie, Dr. Sussman, and Dr. Benoit Laramé. They've been instrumental in initiating the wonderful care for HAE patients in Canada. This is the physicians and treaters currently on the chain board. They spend tirelessly hours on call caring for us. They're wonderful. They help me every step of the way for what we do. Thank you for your dedication and time. These are other treaters along the way and has helped and spoken at our patient updates. This is wonderful, and also nurses. These are the ones we have pictures of, and there's many more nurses that help, and they're instrumental as healthcare providers. These are our posters that we had got developed with the help of our MT and Suzanne Kelly. I'm very appreciative, and I'd like to thank CADIT for letting us, and CBS for coordinating that we could present this to CADIT. I would also like to thank Michelle Boucher from CADIT that helped to review our questionnaire for our National Report Card 2020. Also now, this is how we all were 20 years ago. Before we were fortunate to have CBS approve the first product for those in Canada 20 years later than other countries. And I'd like to thank CSL Behring for that, and then Takeda for coming up, our sponsors who are really helping. And now this is what HAE patients in Canada look like. And it's like a miracle watching everything that has happened. People are really well. You know what? Canada is the only country that took care of their HAE normals. CBS, the treaters, our sponsors, we all have to be so proud. And look, Canada won the Global Walk once again. At HAE Day, May 16th, we had over 1,200 people walking. That couldn't be possible if we weren't as well as we are. Our sponsors are walking, our HAE treaters were walking. We had everyone walking for Canada. This was wonderful. I'd like to really thank everybody. And I want to wish everybody a really happy Canada Day. And I hope everyone is allowed to go out and celebrate this year.
Jackie, thank you for this, and thanks for your thanks. Let me suggest that this is a bit of a model. I mean, you demonstrate that there is hope. The long list of people that you thank, the researchers, the staff, the people at CBS, the people outside of CBS, the companies, it's just a very long list, and it's gratifying to think that we at CBS could play a small part in working with you going through the CADIT process. So thanks for sharing that with us, Jackie. Our next presenter is Dr. Gary Kinsman, Professor Emeritus of Sociology at Laurentian University. Over to you, Gary.
Yes, this is going to be a little bit different because we're switching topic areas to dealing with anti-Black racism and homophobia. 5 minutes cannot do this important topic justice, and this requires a longer discussion. So this will have to be fairly quick, so I hope the translators can deal with this. The initial social organization of both scientific and more popular knowledge regarding AIDS was racist and homophobic in character. This is not only about the historical past, but also very much about the historical present including social responses to AIDS that continue today, including in blood donation policies, including in Canadian Blood Services. It's important to perhaps make a brief comment on, and I'm actually going to have to switch to the other view because I cannot see the thing from here. I'm sorry about this. I have to go back to gallery view. Sorry about that. The first scientific construction of AIDS in the North and West was that it was gay-related immune deficiency, which was translated in popular terms into the gay plague. Now, it's always important when we deal with science to understand that science changes historically. It's always bound up with social relations of power. It's never simply neutral and objective. It always is related to social power and social relations of struggle. But simultaneously with the generation of terms like GRID, there was a major focus on African AIDS and Haitians. And this was built on a long history of anti-Black racism and colonialism and notions of bad Black blood. The term high-risk group that was generated in epidemiology was used to organize discrimination and stigmatization against Africans, Haitians, gay men, men having sex with men, Black people, drug users, and sex workers who I cannot address here. And none of these categories are exclusive. Central to this, and I underline this, was blood donation policies against Haitians, gay men, and other groups. The focus was on groups of people as essential identity groups, as natural or pre-existing, rather than on the actual practices that people engaged in. And what actually spread HIV infection was the actual practices people engaged in. As AIDS activists pointed out, there were no high-risk groups, there were only high-risk activities. I understand that Canadian Blood Services might finally, decades late, be starting to discuss behavior-based practices in terms of blood donation policies. But there's been a long history of the harmful implications of that over the years. The other side of this was the protection of the so-called general population against the so-called high-risk groups. The general population was defined as being white, heterosexual, and largely middle class. And this was also defended by blood donation policies. Blood donation policies were central to the discrimination and stigmatization against various groups of people. This continues in the practices of Canadian Blood Services in the historical present. Canadian Blood Services was formed in 1998. Continues in relationship to Africans, whether it's the continent as a whole or whether it's been specific countries, even if this now has disappeared from official policy. It's continued in relationship to men who have sex with men as well. Although it's got relaxed somewhat, these policies and practices are continued to be carried forward. There has never been any sustained self-criticism of the harm, and I emphasize harm and discrimination these policies have caused to Black, queer, and other queer communities. People do not live their lives only in relationship to one of these categories, and it's important for us to recognize that there are Black queer people, that people experience anti-Black racism and homophobia, that we can't separate all these categories. This leads to the generation within CBS policies and within popular discussion of gay as only coded as white, a sort of false white universal, and a violence of abstraction away from the actual experiences of anti-Black racism and how it is often combined with homophobia, and how that can actually be central to the processes that lie behind what's being organized through CBS. Finally, there is a major need for an intersectional, or what I would describe as mediational approach, such as what is developed in the important work of Dr. Omi Shere-Dryden, such as in these two books, which allows us to think race and sexuality through each other. This makes clear how anti-Black racist homophobia continues in the institutional practices and policies of organizations like Canadian Blood Services. This is what must be addressed. Now I've got 17 seconds left, so I just want to point out that it is necessary for us to actually address the historical past and how it lives on in the historical present. And central to that has been the organization of anti-Black homophobia in blood donation policies, and these have continued in the practices of Canadian Blood Services. Thanks.
Thank you, Gary. Let me take a step back and suggest that I mean, the board has continues to deal with this at just about every meeting. That I shouldn't say just about, at every meeting where we have pressed management on doing two things. One is respecting the science and doing the risk analysis, and the other is updating and modernizing the approach we use for the sifting and categorization, if you will, which is the word you used. What the one thing that the thing you particularly mentioned that I think is interesting and something that we should think about a bit is the role of the past in guiding us in the future. And I suspect that we haven't been as sensitive in that regard as we should be. But let me turn it over to Graham to talk. I mean, and you've heard, I don't know if you were on the call earlier, but we have our plasma policy is to move away from, to move to a behavioral questionnaire away from men who have sex with men as the determining factor. And we're working towards going to Health Canada as the regulator on that, applying to blood. Gary, let me ask Graham to talk and then I'll turn it back to you.
Thank you, Mel, and I'm also just looking to see if the board members have their hand up. Thank you, Gary. Thank you very much for being here. And I would certainly echo your comment that 5 minutes doesn't do this discussion justice. So I look forward to the opportunity to further conversations with you, and I'll make sure I reach out to you following this meeting. There's a lot you raise, and I'll be brief in my response. I want to be clear that this notion that we have not acknowledged that systemic racism exists in this organization, or we have not acknowledged that our policies with respect to men who have sex with men do cause harm and have caused harm. We have made those acknowledgements. I will certainly hear and accept your provocation, your correct assertion that we may have been late in those, but those are acknowledgements we have made. And I guess why I want to continue this conversation and this dialogue, it's how you and others who we will hear following you and colleagues around the country can be helpful to us as we further evolve these policies. The one area you raised that I think is particularly important for not just Canadian Blood Services, but certainly for us and others, is this area of intersectionality. And it is something we continue to focus on and seek to understand and seek to do better. And it's something I'll certainly make sure I follow up with you as well. So I accept what you are sharing with us. I have been very clear in my commitment to the board and to the public whom we serve that our policies will continue to evolve and that we will move away from a policy based on groups of individuals and to a policy based on behaviors targeted at all donors. And that's what I spoke to earlier in my presentation. So maybe I will leave it there, but Dr. Kinsman, I commit to following up with you, and thanks for raising a number of points that do warrant further discussion.
Gary, we have 3 other presenters, but I'll give you a sentence response.
I'll say something really brief. In your responses to me, which I appreciate, you have not actually recognized that very recently there's actually been a significant instance of anti-Black racist homophobia that's taken place at one of your meetings. And second of all, you continue to talk about race as somehow being separate from men having sex with men, when they actually need to be theorized together and thought through together. So there's actually a real need for you to take very seriously the continuing institutional presence of anti-Black racist homophobic practices within the everyday organization of Canadian Blood Services. I'll leave it there unless people want to respond.
No, let's leave it there. Graham acknowledged that intersectionality is an issue we need to take.
The notion of intersectionality that's being used is not actually one that brings these experiences together.
And I want to say that we have, I'm not acknowledging yet that there was an instance of anti-Black racism or homophobia, and that we are looking into it further. In any case, I will now turn to Dr. Stephanie Nixon, who's a professor at the University of Toronto, Temerty Faculty of Medicine and the Dalla Lana School of Public Health. Stephanie?
Thanks so much. Esteemed board members, CBS staff, guests, I'd like to talk with you about equity, diversity, and inclusion, EDI, and propose ways for CBS to think about transformative action. I've had the chance to consult with a number of national health organizations, and it's this experience that informs my comments today. We didn't plan for me to follow Dr. Kinsman, but this is a lovely sequence. It is great news that CBS is moving forward on EDI, but which kind of EDI will it be? There are two main approaches to equity, diversity, and inclusion. First, there is an approach to EDI that is underpinned by principles of anti-oppression and, as just noted, intersectionality. Anti-oppression and intersectionality, by which I mean an in-depth understanding of intersecting systems of inequality, such as heterosexism, colonialism, racism, and anti-Black racism, and how these historic systems structure society, its institutions like CBS, and each of us. This is the EDI pathway that has the potential to meaningfully dismantle inequities related to, for instance, anti-Black homophobia. It aligns with the calls to action we've just heard, actually, from Dr. Kinsman. This approach to EDI is highly uncommon. It is not the norm, but it's what's needed. Second is the approach to EDI that's not informed by principles of anti-oppression and intersectionality. This is the common approach to EDI, especially within the health sphere. It is the norm, and to be clear, this approach to EDI leads to action that reinforces inequity as opposed to dismantling it. It ensures the status quo. And what might this look like? A recent example is CBS responding to these claims of anti-Black homophobia with an independent review led by a team without expertise in anti-racism and anti-oppression practice. I had the chance to read the thoughtful letter written to the CBS board by EDI expert Rania El Mugamar, who spells this out in detail. The review exemplifies non-transformative EDI. It's the kind that looks like action, but ensures no real change on equity. So if this first approach is the one that will meaningfully address equity, why isn't it the norm? Why is it so rare within health organizations? And in my experience, I see two main reasons. The first is that people in health leadership don't understand anti-oppression. Until last year, many had never heard of it. The term itself, along with intersectionality, is at least familiar to many now, but there's little understanding of what this approach means or looks like. There's been little role modeling in health organizations. And this isn't an accident that we don't know. Until recently, education on anti-oppression has been absent from clinical training programs, MBAs. It wasn't even part of my PhD in public health and ethics. So the problem is that health leaders are unaware that the approach they're taking to EDI is ill-informed and counterproductive. But there's a second reason that health leaders don't pursue EDI underpinned by anti-oppressive practice. And that's because this approach is about transformation. This approach is about a fundamental redistribution of power and resources, and that the people holding the power in organizations don't want to share it. And so, as I often do with health leaders, I invite each of you to reflect on where you see yourself in this journey, because this matters dearly for your role in successfully shepherding CBS in the current social political context, or as we just heard from our chair, updating and modernizing the way that we are thinking. So is CBS's lack of engagement on intersectional anti-oppression because these concepts are new to you? Perhaps you didn't even know this is something you didn't know. And if that's the case, that's okay. Now you know, right? You can't unring this bell. It's okay, provided you take immediate, urgent action to address this need. And this is something I can help with, many others can help with as well. It's a big part of my own work in welcoming health leaders into this way of seeing and doing. I use the metaphor of a coin model of privilege and critical allyship to help translate basic concepts in anti-oppression. And I've shared some of those resources in the chat box. This is more than a 5-minute issue, so I'm also happy to follow up afterwards, should anyone wish. Or is the reason because, not that you don't understand, but you do understand anti-oppression, but that maintaining the status quo is in the interest of those in leadership positions. And so an approach to EDI that gives the impression of action while actively reinforcing inequity isn't an accident, right? It's intentional. And if that's the case, then it's the job of those of you at the CBS leadership tables who can see what's going on, right? Who can see clearly, to interrupt this dangerous pattern, to figure out what it means to hold the organization and staff to account, and to move swiftly to ensure leadership at CBS that's capable of delivering on the government's own 2021 call to action on anti-racism, equity, and inclusion in the federal public service. Thank you.
Thank you, Stephanie. I guess the key thing that I want to reconsider, if you will, is the notion of what you characterize as the two approaches to EDI. I think we have, I don't think there's been a board meeting since, I don't know, the last 3-4 years. Certainly, I've been on the board in 3.5 years now, where we haven't talked about, actually, we call it DEI, but that's fine. I think we are committed to a policy and program of diversity, equity, and inclusion. And there are, we can only operate on the instruments that we actually have within our power. We are looking at utilizing all of those instruments to the extent that we can. But let me ask Graham to talk a bit more about the DEI policy and where we go with it.
Thanks, Mel. I can, but Mr. Chair, if you'd permit me, I actually want to respond slightly differently to Dr. Nixon. I just want to say with utter conviction that it is not rooted in any desire to retain the status quo. So the desire is absolutely there to go down the first path. And I will admit, I may not have all the tools and the language and the knowledge, but there is certainly the recognition that many of our practices are rooted in anti-oppression and colonialism. So I just want the declaration to be clear that there is no desire to retain the status quo. And so how we go through this journey, what learnings we need to do as an organization in order to mature our capabilities and our presence in Canadian society. That is what this journey is about. But I just want to be totally declarative to you, Dr. Nixon, and I too will follow up with you, as I said I would with Dr. Kinsman. There is no desire to retain the status quo here. This is absolutely about carving out a new path and doing it in a way that recognizes where we have come from. So it's probably about as much as I can say now, because it's both for me personally as the leader of this organization, a learning journey. It is for the organization as a whole. But I think given the way you framed it helpfully, I want to declare for all that there is nothing rooted in retaining the status quo here. So that's probably about as declarative as I can be here, and look forward to a furthering of a discussion with you.
Thanks. Our next presenter is
May I
Renee.
offer a brief response?
Very brief, please.
Sure.
We have two more presenters.
For the comments that you've just offered, and that it requires a kind of humility, right? This new way of engaging around anti-oppression. Also, one of the very first principles is to uncouple intent from impact. And often what we do is get too caught up in intent and the intention to do good that has led to some of the most egregious inequities in our country and internationally that we've got. And so we definitely want good intent, but now it's time to set that aside and realize that these are ways of thinking and doing and knowing that are sophisticated, complex, and require new expertise brought to the table. Thanks so much.
And thank you. And I commit that what we're looking for are results. And you know, we know you'll be out there judging us on this, so as you should. Our next presenter is Renee Dumarek, a member of Showing Up for Racial Justice Toronto, a registered social worker and a PhD candidate at York University. Renee, over to you.
Hi, everyone. I wanted to address the Canadian Blood Services Board of Directors today as a white queer person who's deeply invested in, but also have concerns about the lack of an intersectional approach taken by Canadian Blood Services in addressing discrimination in policies and practices, as well as discrimination at the systemic, institutional, and interpersonal level more broadly. And my concerns have been exemplified and also exasperated by the board chair and the opening remarks, as well as comments made by the CEO today, because when discussing the impact of blood banning policies on LGBTQ community, neither mentioned how racism figures into these issues. And I know this has already been mentioned by Dr. Gary Kinsman and Dr. Stephanie Nixon. But this is so important, right? Because the specific harm caused to Black community and Black queer community, they've been doubly targeted, right, by CBS policies and practices, historically and ongoing. Research by community experts, advocate, scholar, Dr. Homi Shrey Dryden, as Dr. Kinsman mentioned, has identified that Black communities, in addition to being impacted by policies that exclude men who have sex with men and other members of queer and trans community, have also been discriminated against by screening practices that up until 2018 falsely equated countries in Africa with HIV. And so these two pieces are interrelated. They're not separate, they can't be separated. Discrimination has also always been justified by claims to science, right? And this has been the case for each iteration of policies governing CBS screening processes. We know that science has never been wholly objective. It's always value-laden. And that so-called evidence-based practice is developed and it's unequally affected in a manner that reflects an interpretation of what we refer to as the results of science. And it's always based on broader ideals and values that govern society. And I think it's just important to say that queer communities will not accept a response from CBS that doesn't acknowledge racism, and specifically anti-Black racism and anti-Black homophobia within both the history and the contemporary context of CBS, because racism is a gay and a queer blood issue. And in addition to the policies and the practices, it's also important to focus on how the conversation surrounding these policies and practices, while they're in effect and also after changes are made, and the narratives circulated about them, including who they affect, really works to construct a group of people and a problem in a particular way, including who is understood as belonging, who's understood as being inside and outside of Canada. When Black, Indigenous, and racialized communities are not included in an intersectional approach to addressing harm, then it suggests that only some queers, white queers, are being invited in. And again, this is suggested in who was addressed in the remarks made today by the chair and CEO. There's still been no public acknowledgement and repair made around the exclusion of Black communities. And that really demonstrates a blatant contradiction to the acknowledgement, the CEO and the chair's claim to have acknowledged systemic racism and demonstrating commitment to equity, diversity, and inclusion and a supportive work environment. Highlighting more queer people and more people of color in the organization doesn't disrupt the systemic nature of racism, harm, and harassment. What Dr. Stephanie Nixon and Dr. Gary Kinsman's presentations both support is an understanding that any effort towards equity, diversity, and inclusion really has to include listening to and responding to concerns raised by community. This acknowledgement of systemic racism made today and commitment to diversity, equity, and inclusion, and commitment to safe working environments, which you claim encourages a dialogue at CBS, has been further undercut by the board's failure to take meaningful action to address harassment against Dr. Dryden after she called CBS to account for systemic anti-Black racism and anti-Black homophobia. A facilitator was contracted with no experience doing engaging anti-racism at the organizational level or at all. And there's been no response from the board to an email sent by a community expert and anti-oppression and anti-racist consultant, Rania El-Magimar. How can you investigate anti-Black racism and racism without an expert in anti-racism, right? And so it's time to hold staff to account. And so if there is a genuine commitment to the objectives outlined today, then I urge you to, as members of the board, to speak with community experts and respond to the demands recently issued in several letters that have been sent. The time is now. Thank you for your time.
Thank you, Renee. You mentioned the letters that have recently been sent. Indeed, I am collecting them, and we will respond to each of them. And obviously, there's a lot of overlap. But I just want to come back to what you characterized as harassment, and I do not, which was that incident with Dr. Dryden. And as I said, we are looking into that. We have hired someone. I know that the person is not up to your standard, but we will take it seriously. It is not this organization's intent in any way, and Dr. Nixon made the distinction between intent and results, but it is not our intent, and we do not want to merely accomplish an organization that is free of harassment. We want to be one that is promotive of inclusion, about diversity. I mean, and frankly, let me just open a window, and I'll ask Dr. Scher to expand on this, if you will, Graham. The results we get in terms of serving our communities is dependent on diversity. It isn't just because it's the right thing to do, which it is, but if we don't have the right kinds of contributors of stem cells, if we don't have the right kind of donors of blood, we will be inadequate in serving Canadian patients who need it. So this isn't just doing the right thing, which it is, and I'm not disavowing that, but it also affects the quality of results. Graham, do you want to elaborate?
Well, I guess just to say, Mr. Chair, that, yeah, a lot of our recruitment practices are aimed at ensuring we can collect products from all sectors of society, because there is an important need that is essentially biological matching between recipients of either stem cell products or fresh blood products. I am aware of correspondence received just today that we do not enable the collection of blood products to meet, for example, recipients who are Black. That is not true. I mean, we work very closely and very carefully to ensure that we can match the needs of patients with sickle cell disease who have very specific blood product requirements. So, I mean, there are many examples around that, Mr. Chair, both in the stem cell world and the blood product world. We can provide lots more data on that. You know, my comments, Ms. Dumaresque, are the same as I had said to Dr. Nixon and Dr. Kinsman. This organization has a learning journey. I have made that very clear, and I look forward to further engagement. I think you're all aware that I made an outreach to and will be meeting with Dr. Dryden next week. I had hoped to have that meeting sooner, but calendars did not permit, so she and I are meeting next week. I feel that that's a really important thing to do. I was insistent that that meeting happen. So I do want to assure and commit to all that this dialogue will continue.
Thanks. Renee, one last quick comment, please.
Yes. I mean, just a couple of really quick pieces. it's not my assessments solely of the facilitator. It's a really critical aspect of doing anti-racism work, is that when you're engaging somebody to actually make an assessment and to make recommendations and to correct course, that's in alignment with a commitment to equity, diversity, and inclusion, that you hire someone with an expertise there, or else there's absolutely no way to get direction that's actually aligned with your strategic objectives, right? And I mean, there's a clear bias in your suggestion right off the bat that it was not harassment.
Well, it's not a bias. I'm not going to let you say that. Don't tell me I'm biased. This is a serious issue that we are taking seriously, okay? It may or may not be consistent with the way you would like to see it done, but it's the way we're doing it.
I can tell it's the way you're doing it, sir. But just, you opened up by saying it's not harassment in your opinion, and that really speaks quite volumes.
Okay, thank you. The next presenter is Dr. Nathan Lachowski, Associate Professor at the University of Victoria, and we're out of time. No, I'm joking. Please don't lose your sense of humor. Dr. Lachowski, over to you. Nathan.
No worries. Thanks for the 5 minutes, and I've already notified future meetings that I might be late. Thank you for the opportunity to present today, and I want to acknowledge and respect the Lekwungen people, whose traditional territory I'm calling in from today. It's an honor to follow the previous 3 speakers in particular and build on their comments. I'm a white cis gay man. I've both donated blood and been deferred from doing so. I'm also a researcher at the University of Victoria and with the Community-Based Research Center. We've received, in full disclosure, research funding for several projects through the federal government's investment in CBS's MSM Research Fund, and we're grateful for the support. I am concerned about CBS's transparency and process in addressing intersectional anti-Black racism, homophobia, transphobia, and other forms of oppression, as other speakers have outlined. I've been editing on the fly because of many of the brilliant comments that people have made previously, but I do want to make a few key points. The first is that acknowledgement is not apology nor action. And so I look forward to the future pieces related to that. The second is that this is not just about the donor screening policies. It is about far more. So I would like to provide a few examples of how a very quick analysis of CBS's work recently and since the DEI statement in November 2020 demonstrates failure to their intent. So just this Pride Month, a new LGBTQ+ communities page was added. Nothing in this page refers to Black people. Nothing in this page refers to Two-Spirit and Indigenous communities. There is simply a reference to, quote, other persons. Pride Month exists because of the activism of Black, trans, and queer people of color. This new CBS page erases their contributions towards justice, both historically and today. Let's take a second example. The page about, quote, evolving criteria for gay, bisexual, and other MSM. It does not say anything about Black men. It does not say anything about trans men. It's another example of failing to take an intersectional approach. So your commitment is not leading to your intended impacts, so a change is needed. Over the last few years, I've been engaged with CBS and I've worked with some incredible people. However, I've also witnessed several failed opportunities to do better and to live your commitment to DEI, both in public meetings and events. In particular, the intersection of anti-Black racism and homophobia and transphobia, as many have talked about so far. There's not been an appropriate and sufficient public apology from CBS regarding their historic and ongoing policies and practices that harm various marginalized communities, and not just one dimension of one community. Surely if Harper can apologize for Indian residential school system survivors and Trudeau can apologize for LGBTQ2 communities, surely CBS can take this important initial but not sufficient step. Many people have talked about my colleague, Dr. Dryden, and much of her incredible work in this area. So I just want to outline that she's made many claims and recommendations around how to begin practicing anti-racism. I urge you to consider these carefully and to implement anti-racist practices and policies. I know you're meeting next week, Dr. Scher, with her, and I look forward to seeing the ongoing conversation that comes from that. I think we need to recognize as organizations largely created by and for white, cisgender, heterosexual Canadians, and looking around the Zoom room, I see that reaffirmed, at least in my read of many of you, that we must be prepared to engage thoughtfully when those who do not share in our privileges highlight our failures to be inclusive. It was clear that CBS staff were not prepared to acknowledge these systemic failures in the altercation on April 29th. CBS is no doubt and importantly a life-saving institution that is highly dependent on the goodwill of Canadians, particularly blood and tissue donors. We cannot claim to be concerned with the maintenance of this goodwill if we do not intentionally center the most marginalized voices in our policy dialogues. Ongoing concerns regarding racism, homophobia, and transphobia are actively undermining Canadians' goodwill, and they raise serious concerns about the future sufficiency of the blood supply. Like others have offered, I'm happy to help.
Thanks very much, Nathan. First, a comment on your intervention, and then let me pick up a theme from the last four. I like the way you linked it to the dependence we all have on the goodwill of Canadians, and frankly, on the quote MSM policy, and I know that that's an inadequate way of characterizing it, but it's short form for now. This is one of those curious circumstances where people are beating down our door wanting to give blood. This is a good thing. This is this community's commitment to helping other Canadians, and so we should be facilitating that. The caveat or the condition for that is that it has to be based on science and has to be a risk-based approach, which is, and I will be totally in agreement that the risks are not sexual orientation related. The risks are behavioral, and that's what we're working towards. And so white cisgendered male individuals may or may not be engaged in the similar activities, behavioral activities that we want to screen out, and we need to get to the point where we're screening out the right thing. Dr. Kinsman's point, I almost said and didn't say, and I'm glad I didn't say it then, but I'm going to say it now, and Gary can follow up with me afterwards, that we have been iterating towards an appropriate policy. And what I accepted his point about the past, and I want to build on that. I do want to acknowledge the past. You made the point about an apology as a way of addressing that, and that's something that we should think about. So let me just turn to the last four presenters and note that you have given us a lot to think about. Dr. Scher's mentioned that he's meeting with Dr. Dryden next week. We all look forward, and in fact, we're having a meeting with Graham on Thursday of next week after he's met with Dr. Dryden. And this is going to be a live issue. I mean, it is a live issue. It's something that we have been dealing with. As I said, EDI or DEI, we've been dealing with it for a number of years because of the quote MSM policy. We've been dealing with it at the board continuously over this period. We will continue to, and I hope, I said this about Angela Diano, that I hoped that she wouldn't have to appear before us again very soon because we were successful. I hope that we are very successful and that we won't have to have this conversation again, and that we will meet your test of what is a modern, updated organization. Graham, can I turn to you?
I'm not sure I have much more to add, Mr. Chair, other than to say to Dr. Lachowski, thank you very much for the ongoing work you do in this space. It's been an important collaboration. We're very grateful for the science, the evidence, the data, and the thought-provoking outputs your research has produced, and for the ongoing collaboration. So I too will follow up with you as well. I mean, I would certainly echo the last comment that from all four presenters, this has been important for us to hear and to listen to. And I certainly want to thank all of you for making the time to be present, and certainly Dr. Lachowski for the ongoing research you've done in this space.
Dr. Kinsman has his hand up, but I'm really worried about the time, and I wonder if you could make your comment in the chat. All right, a very quick comment.
Well, if I could go first, just as the prerogative of other speakers have had.
Yes, you have. You have. Go ahead.
Just quickly. I do hope we're having a different conversation in a year, but I really want to caution the board and the leadership that this will not be solved in a year, and to really not rush this. I think a demonstration of this is that the invites for the MSM apology meeting on April 29th were sent 48 hours in advance. That is the issue of trying to rush this is going to be a problem. So please take your time.
I agree.
Not to also say not to do anything, because we are here and we are watching and we are with you in terms of trying to make change. But I think that this is important to recognize that this issue will not go away and it will continue to be an issue next year, but hopefully it will be a different conversation that we're having.
I agree completely.
Yeah, I hope we are assessing the progress we're making, recognizing that it isn't complete. Gary, last comment, one sentence.
Yeah, anti-Black homophobic racism was organized at the very beginning of the AIDS crisis, and it continues to live on today in the institutionalized practices of Canadian Blood Services. You need to address this centrally and seriously.
Thank you. So I make a commitment as chair of the board that we will address it seriously and hopefully quickly. Thank you. Look, I want to thank all the presenters. We had 7 presenters today. We can wrap up this virtual board meeting. Let me just say to others who are listening in or watching this that we welcome your feedback. This has been, I think, a helpful interaction to plan for the future of the organization and how it will evolve, both in terms of the first 3 blood-related issues and the last 4 institutional and behavioral questions that have been addressed. And feel free to submit comments to engage@blood.ca. This marks the end of the open board meeting, and I thank you all for your participation. Merci à vous.